1 minute to go. They're on time. Thank you. Good evening, friends. Indeed, I'm happy to host yet another important clinical session for the postgraduates. We have eminent faculty from across the country and brilliant students which have been participating from across the country. Today, we have invited faculty, Professor Ranayake Singh from RML Hospital, New Delhi. Welcome, sir. Thank you for joining us. And we have Professor Apurva Shah, Professor and Head of the Department from BJ Medical College, Ahmedabad. Welcome, sir. We have Professor Dr. C.R.K. Prasad, sir, from Hyderabad. Welcome, sir. We have our own senior friend and teacher, Professor Marthupandian, sir. He was the HOD of the surgery and then he was retired as the Dean of Madurai Medical College. Thank you for kindly accepting our invitation, sir. And we have our academic committee senior team. We have Professor Ajay Khanna, sir, Professor Sahai, sir, Hitesh, sir, G. Prakash, sir. And we have, I could see a lot of other professors, Professor Jayesh Parekh, and I'm sure Ambuja Madam is there. We have Professor Rajgopal Chennai, sir. Then we have Srinivasan, sir. I think a lot of senior faculty have joined today. Professor Srihari Rao, and we can see the senior faculty for the evening. Chennai, sir, good evening, sir. Welcome, sir.
Good evening to everyone. Everyone.
Yes,
Lot of people.
yes, sir.
Namaskar.
Yes, sir. Today it's full house.
All ASI is represented very well here. So,
Namaskar.
Namaskaram, Maruthupandian, sir.
Good evening, sir. Good evening.
Prasad, sir. Our
Namaskaram, sir.
main
Namaskaram,
person
sir.
who looks after the money in Sir, Ramanaya, sir, also I saw. Prakash, sir, I saw.
Yes,
Oh,
sir.
great, sir.
Namaste, namaste, boss.
Tirupati.
Namaste.
Namaste.
Ramaniya
Dr.
sir and Srihari sir are there. Huh?
Yes, sir. Namaste, sir.
Srihari, sir, is also there.
Namaste.
Good evening, sir.
Sir, namaste.
Good evening, sir. Good evening, sir. So, I think we have everybody up, and I'm sure today's class is going to be energetic. I should thank the faculty for this evening, Professor G. Prakash, sir, for kindly contributing. Dr. Ganesh Reddy Eluru, he is going to present a case of multinodular goiter of the thyroid. And we have Dr. Shweta Suttar. Dr. Shweta Suttar is from Ahmedabad. She is kindly contributed by Professor Pankaj Modi, sir. And I'm also happy to share Pankaj Modi, sir, is graduating her postgraduate education from University of Maryland. So Modi, sir, may not be joining us today, but he has wished us well for the evening's class. And with that few words, Dr. Shweta Suttar will be presenting a case of chronic non-healing ulcer of the foot. These are the two cases. For the invited faculty and new to this forum, sir, this forum is like a teaching forum. The candidate is first allowed to run through the history part of it without stopping. At the end of history, the candidate will sum up the history. I would request the invited faculty to correct them if they have missed out on anything. And you can definitely ask questions on various issues. And I would say if the candidate is unable to answer, please give them the right answer and ask an examiner what you will expect. This is a sort of a teaching class like, sir. So that is how we do. And at the end of the clinical part of the history part of it, the candidate is allowed to run through the clinical finding without stopping. At the end of clinical part, the candidate will sum up the clinical finding and arrive at a reasonable diagnosis to work up the patient. So the examiners stop there, ask questions on the clinical finding. They can go back and revisit the slides whenever needed on the clinical finding or how to elicit the clinical finding. All those questions are asked. And after that, they go through the management part, and operative surgery questions are also welcome. And I would request the faculty to concentrate at the end little bit on the operative surgery and complications, because many students have asked about the steps of the surgery. So depending on the case where surgery is needed, maybe you can touch upon a little bit of operative surgery. I plan to give them about an hour's time for each case. So let it go as a teaching module. Please help the students if they are stuck or something. Please give the answers, and of course our own senior faculty member who are with us through the journey of last 1 year and 1 month, they'll be also be able to contribute and chip in more points and additional points for the benefit of the postgraduates. With that few words, I wish all the good luck for the students who have been kind enough in presenting cases today. The students are requested to first tell their name, their unit chief's name, and the head of the department's name, and whoever as the assistant professors who have helped them to present the cases, both the student. And I'm also to share these cases are already presented in the department so that they are already tuned up. So I'm sure the students will do well and take up the challenge of the questions from the national faculty very well. So Dr. Ganesh and Dr. Shweta, wish you all good luck. And I would request Dr. Ganesh to start his presentation. Over to you, Dr. Ganesh.
Thank you, sir. So good evening, sir. Good evening, respected professors. My name is Dr. Ganesh Reddy. I'm final year postgraduate from Sri Venkateshwara Medical College, Tirupati. I am presenting this case under esteemed guidance of our HOD, HOD sir, Dr. G.V. Prakash sir, and Dr. N.V. Ramane sir, and Dr. Naumane sir. So, my patient is a 42-year-old lady. She's a resident of Chittoor district, housewife, and she came with a chief complaint of swelling in lower part of neck for the past 2 years. My patient was asymptomatic 2 years back when she first noticed a small swelling in front and lower neck on left side while dressing. Swelling was insidious in onset, gradually increasing in size and attained the present size. Swelling was not associated with pain, no history of fever. She doesn't have any history suggestive of hyperthyroid symptoms like excessive sweating, tachycardia, palpitations, and other symptoms. Any symptoms suggestive of hypothyroidism, pressure symptoms, no history of rapid weight loss, no history of loss of appetite, no history suggestive of metastasis, no history of rapid increase in the size of swelling, no history of any other swellings in the neck. Past history, she doesn't have any history of similar swellings in the past. She is not a known case of diabetes mellitus, hypertension, bronchial asthma, tuberculosis, and other chronic diseases. No history of previous hospitalization, no history of irradiation to neck region in childhood, no history of any previous surgery. Patient personal history, patient consumes mixed diet and iodized salt as a part of her diet. She drinks municipal tap water. There is no history of excessive consumption of goitrogenic substances. Bowel and bladder habits are normal. Normal sleeping pattern. Her appetite is normal. There is no history of any allergies. Menstrual history, sir. She attained menarche at 12-13 years. She has regular cycles with normal flow, 4 to 5 days out of 28 to 30 days. It is not associated with pain or clots. She is married at 20 years of age. She is para 2, live 2, uneventful, normal vaginal deliveries. She no history of postpartum hemorrhage. First child was born after 1 year of marriage and second child after another year. She breastfed both of her children 6 to 8 for a period of 6 to 8 months. No history of abortions. No, she was tubectomized after second delivery. Family history. She has no history of similar complaints in family members. No history of cancers or hereditary diseases among family members. To summarize my history, a 42-year-old female lady, presented with painless swelling in front of neck for the past 2 years, which is insidious in onset, gradually progressive, with no pressure symptoms. Clinically appears to be no other systemic symptoms.
Very good, Dr. Ganesh. Why
Sir.
should you ask for history of irradiation?
Sir, in olden days, irradiation was used for treatment of some diseases, sir, like acne vulgaris, tinea capitis, and Hodgkin's lymphoma.
So what?
Irradiation can cause malignancies after 5 to 10 years, sir.
What malignancy.
The most common lymphoma and papillary thyroid carcinomas.
Papillary carcinomas. Which age group is more vulnerable? Irradiation in the age group of adolescence or old age? Which one more commonly precipitating this papillary carcinoma?
Adolescence, sir.
Exactly. Good.
Dr.
Yeah.
Ganesh, no?
Yes,
Ganesh,
sir.
no?
Yes, sir. Yes, sir.
I have two questions to you.
Yes, sir.
I think acne and all you should forget now, because that has been a long backstory. Now nobody does that. So
Okay.
if you ask me, what do you think the most common cause of irradiation during childhood presently? Now, can you tell me a few conditions?
Sir, leukemias.
So you need to understand few things, whether it's a leukemia, lymphomas, nasopharyngeal, childhood malignancies, head and neck malignancies during childhood. Okay. And
Okay, sir.
do you know any other ways of irradiation now? Not just for malignancies, anything else? So much CT scans of the head and neck have been done. So remember, those irradiations, they have more important than acne and all. Don't mention acne. Second
sir.
question to you, what is the most common side effect in thyroid related to radiation? I asked you most common.
Sir, thyroiditis.
Hypothyroidism. Okay, hypothyroidism. Okay.
Okay.
Sir, please take over.
Yeah. Ganesh, no?
Yes, sir. Yes, sir.
Yeah, Ganesh, you were very specific saying that your patient started with a painless swelling in the lower part of the front of the neck. So from the history, you would assume that this is a thyroid swelling, what you are dealing with. Okay. So what are the painless swellings? What are the painful swellings you get in that region of upper part of the lower part of the front of the neck?
Sir, most of the goiters are painless, sir. But the painful swellings are large nodular goiter with hemorrhage, radial thyroiditis,
Okay.
anaplastic carcinoma causing infiltration of RLN.
And you also mentioned that it is gradually increasing to the present size. Okay.
Yes, sir. Yes, sir.
Now, what swellings increase gradually or insidiously? What are the swellings in that region? Duration and their interpretation.
Duration.
Oh, yeah. You said 2 years since it is growing gradually. Okay. So
Yes,
this what are the various levels of durations? What is the various levels of increase in size, and what is the inference, especially in the lower part of the front of the neck?
Sir, gradually increasing swelling, solitary nodular goiter, multinodular goiter, and colloid nodular goiter, they increase gradually, sir.
Okay.
Usually over a period of years only, sir.
Okay.
In case of malignancies, there will be recent onset, rapid increase in size, sir.
Okay. Still there some more differential growths are there.
Sir, thyroid cyst.
How do they grow?
The thyroid cyst, they will go for a period of 6 months, sir. After that, most of the time, they will remain static, sir.
Okay.
In case of thyroiditis, sir, there will be initial increase in size, followed by, after the inflammation subsides, size may decrease, sir.
Okay. So from the history alone, actually, you can differentiate all these types of swellings, which are benign, nodular, malignant, all that, and inflammatory. Yes. Sir, Rana sir.
No questions, only one suggestion through Ganesh to close to 90 postgraduates who are attached with this meeting. And the suggestion is, nobody has ever passed a master's examination without confronting thyroid. Whether it's a short case, operative, specimen, I mean, one way or the other, thyroid is out to cross you. So that's a suggestion, and that is what I tell my postgraduates. There is a list of symptoms of hyperthyroid and list of symptoms of hypothyroid. while in the examination, if you start recapitulating that yes, patient's appetite is good, lean, patient is overweight, the skin is thick, the hair is sparse, then you are going to miss few points. So I tell my postgraduates that you have to remember the features of hyperthyroidism and hypothyroidism. Jot it down on a piece of paper. First, say hyperthyroidism and all 1, 2, 3, 4, 5, 6, 7, and then hypothyroidism 1, 2, 3, 4, 5, 6, 7. And in between, keep on looking at it, because like during the examination you were too hard pressed, and these symptoms you will have to confront in the examination. So that's a practical tip, that jot it down. In between, keep on looking at that piece of paper, so that you keep on revising. So that's a practical tip, and that is what I tell my postgraduates. And I think he has presented the history really very well, except that there is no history of surgery and other things. Those things could have been omitted, but no harm.
Dr.
Ganesh?
Rana sir, can I ask something? Yes. Ganesh,
Yes, sir.
your first slide, you are written there, no other systemic symptoms, correct?
Yes, sir.
Always.
Go to the slide, Kana. Go to the slide. What sir is referring? First slide.
No, I'm saying, sir, that.
Okay, sir. Okay.
Yeah. I just want you to understand, first, everything related to the swelling you should ask. Once you ask, then only you should progress to the other one, because show the second slide now. Yeah, you just see now, you are written there, increasing in size and all. Go to the next slide. And you see the first 3 lines,
Yes,
and
sir.
then you see the 4th line.
Sir, I wrote a rapid increase in size of swelling.
So please do not do that mistake in the exam, so that otherwise you'll miss. So one thing related to the swelling, when you say, this should come. No history of rapid increase. Rapid means probably malignancy. Sudden means hemorrhage. Once that is done, all related, then Rana sir has already told you, hyperthyroidism, hypothyroidism, etc., etc. I hope it is clear. Message is clear.
Yes, sir.
First is related to the swelling, then related to the local compression features.
Symptom.
One mentioned there, but it would have been nice if you say no history of difficulty in breathing or difficulty in swallowing or hoarseness of the voice. Then history of rapid increase, that you have written there, but now. So later, hyperthyroidism, hypothyroidism, and malignancy. That's all from my side.
Dr. Ganesh?
Yes, sir.
When you are asked causes of swelling in front of lower part of neck, you are focused only to thyroid. Even in your history, you have from first sentence presumed that it is thyroid. Ideally, you have to rule out the other causes as per the age group and the gender as well. This is one point I like to highlight. Another thing, you have mentioned so much about breastfeeding.
Yes, sir.
It is not needed in this case, right?
Yes,
So
sir.
unnecessarily you are wasting your half a minute or so, which you can encash at the end. So just this is a suggestion, right?
Ganesh, you have again and again been pointing out it's a 42 years old lady,
Yes, sir.
Okay, that is not a good term to use. 42 years is not an old one. Then I think we are on then the fossils. Okay. So, even the WHO has defined up to 65 years as a middle one, not even the old one.
Okay.
Okay. So,
Okay, sir.
please do not, when you make or presentation for it, just say it is a 42-year lady who is there.
Okay, sir.
Right? Second, you have written there is no history of metastatic symptoms here, isn't it?
Yes, sir.
So, which metastasis you thought in a patient with a 42 years female patient presenting with a goiter?
Sir, 42-year-old female, the most common malignancy is follicular carcinoma thyroid, sir. We might expect bony metastasis and lung metastasis. In case of bony metastasis, we can ask for any swellings in the scalp or any chest wall or pelvic cavity, pelvic bones. And in case of lung metastasis, we can ask for cough, sir, and hemoptysis.
Yeah, so that you should come out, rather than saying, from that it appears that you are dealing with a case of you know about probably the diagnosis, and you are coming out with that metastatic symptom.
Okay.
But if you simply say that this patient doesn't have the cough or the hemoptysis is there is no bony swelling. These are two places. Like in the breast, if it is the breast is there, it can go to anywhere. It can go to the brain, it can go to the lungs, it can go to the liver, it can go to the adrenals, anywhere it can go. But as far as the thyroid carcinoma is concerned, it will go only at two places.
Okay.
Either it will probably go to the bones for pulsatile swelling which is there, or it may go to the lungs.
Okay.
These are the only two places where it will go. So you can specifically ask about that.
Yes, sir.
Ganesh, you have written, he had a children, he has breastfeeding you talked about. How many children he has?
She has 2 children, sir.
So she has a home delivery or a hospital delivery?
She delivered in a hospital, sir.
But you said no hospitalization?
Oh. I'm
no hospitalization. But most of your history, what we are seeing is you are making a very, very solid statements. No chronic diseases, all these things you cannot if you put that everything negative, then it is, you may end up in a problem. And no evidence, we are very, very categorically saying no hypothyroidism. Probably the patient would have been obese. That are also a feature of thyroidism. So don't put a very categorical statements there. When roughly we are putting no hospitalization like these things.
There is a dictum to be remembered by PGs that error of omission is always better than error of commission.
Yes, yes, always.
Dr. Hemant Kumar, sir, I saw your hand go up, sir. Dr. Hemant Kumar Natir from Himachal Pradesh.
Yeah, it's right,
Yes, sir.
sir. Dr. Khanna has addressed that question. I was going to ask, he has written no evidence of metastasis. So instead that he should write there is no history of hemoptysis or bony tenderness like that. The same question I was like,
Thank you, sir. Thank you.
Yeah, I think as Dr. Hitesh sir is told, see, Ganesh, you have taken for granted that this is thyroid swelling and you are going to the extremes of metastasis and all that thing. For all that matter, patient with a 2 years duration, can you think of anything else other than thyroid swelling in that area? I have not seen the patient now. You should have put the first patient's figure, but I just want to, you said left side of the neck, no? Correct?
Yes, this is the clinical image.
Okay, yeah. Can you tell me what are the other swellings can come other than thyroid? You can go back now, go back, yes. Quickly, what other swellings in that region can come which is other than thyroid?
Sir, we can lymph node, sir, lymphadenopathy.
So which lymph node can come as 2 years duration? See, this is how the questions will be asked.
Basically,
so tuberculosis less likely, it would have gone to cold abscess, etc. Malignancy highly unlikely. Low-grade lymphoma, single lymph node unlikely. If at all, it can still be a papillary carcinoma thyroid. That is a different issue. I wanted you to remember parathyroids can come there. Correct?
Parathyroids.
So, parathyroid can come there, and neural tumors, vagus, nerve sheath. So you know this triangle, na? So this is how you should try to keep it in mind before you proceed. Yes, sir.
Yeah, I think Ganesh, some more things, what you have told in the history, that she takes municipal water. That's what you told. I don't know what you mean by this municipal water. One. Second thing, again, in the history, very detailedly, you have said she had a normal vaginal delivery, uneventful with no postpartum hemorrhage. See, all these things you are going to commit and you have to prove why you have asked these things with relevance to your case. Yes.
Sir, the type of water consumed also has an importance, sir. A patient
So,
consuming water.
why specifically municipal water? What does this municipal water contain, or what does it lack?
Sir,
you have any idea?
In Woodland, iodine supplementation through water is also given, sir.
Okay.
And board water contains.
Hang on. Ganesh, hang on. Where have you heard of iodine supplementation by water? I have not come across it ever in my life. Can you give me an example? It's never done. Look, taking a detailed examination doesn't mean you can take detail about the kind of clothes she's wearing. That doesn't help you.
That's it. That's it.
You should take detailed examination about her complaints, which is specific to her complaints.
Relevant to that.
Matter, right?
Yeah. Okay. So one or two, even if you leave out, can be excused. But if you talk about it, then you must have a rationale behind that with relevance to the complaint or swelling for which patient has come to you. Okay. Okay.
Professor Apurusha, sir, you would like to add something, sir? Sir, you are in mute mode, sir.
Actually, basically, I was listening to the conversation. And everything is everybody has said is perfect. You need to be very precise in what you are asking. I mean, we cannot have a whole story of the patient without the particular character into. So already we have already discussed. So I don't want to pinpoint anything now.
Thank you, sir. Thank you, Dr. Hemant, sir. I
Yeah,
saw your hand go up, sir. Yes, sir.
yeah. So just want to point out to the residents, they often confuse normal delivery. They say normal delivery without any postpartum hemorrhage. Normal delivery definition, when you say normal delivery, it means a spontaneous per vaginal delivery with the vertex position between 37 to 42 weeks without any assistance and no complication to the mother and the fetus that is infant. So when you say normal delivery, it means everything is normal. Then you don't have to add it is a normal delivery and there was no postpartum hemorrhage. Child was not with any problems. Right. So this is very students, they say normal delivery and then they start adding words to it also.
Ganesh, don't treat this as a gynec case here, please.
Exactly, sir. This is what I was going to say.
I myself do not know why you bring this postpartum hemorrhage as if everybody is getting postpartum hemorrhage. See, moment you make a statement, moment you, for example, tuberculous lymph node, if you make a statement that there is no history of fever, that means most of the patients get fever. You understand what I'm telling? If you make a statement like this, no postpartum hemorrhage, what does it mean? That means everybody gets a hemorrhage. So it's not a gynec case. Don't get into trouble.
Ganesh, you'll be asked then causes of postpartum hemorrhage and its management. Okay.
That's why I said so. Once it is normal delivery, it means everything is normal. You should know the definition of the normal delivery.
Even that is not required, sir, in thyroid case.
Yes,
yeah.
Yes.
So, the effect of PPH on the pituitary or thyroid?
Sir, Sheehan syndrome is there, sir. It can result in a secondary hypothyroidism.
Okay, go ahead. Good.
Shall I continue, sir?
Yes. Sir, Rana, sir?
I think we should allow him to continue.
Yes.
Yeah. Like one thing, I think I must tell the panelist that he is halfway through his time, close to halfway. So
no, we shall.
Continue.
Yeah.
The general examination, sir. Patient is cooperative, well-oriented to time, place, person. Her mental state and intelligence appear normal. She is thin built with moderately nourished. No signs of dehydration. No loss of hair. Eyes pallor present. No icterus. No loss of hair in the lateral part of eyebrows. No eye signs are present. Yes, no puffiness, cyanosis. Facial expression is normal. Oral cavity normal with good oral hygiene. No swellings in the oral cavity. Tongue is normal in size. Hands, no tremors, clubbing, excessive sweating. No clubbing of fingers. Nails were normal. Feet, no pedal edema, pretibial mixed edema. Skin normal without any excess sweating and dryness. No vitiligo. No generalized lymphadenopathy, proximal myopathy. Vitals, sir. Pulse rate 78 beats per minute. Regular rhythm, normal in volume and normal in character. No vessel wall thickening. No radial and radiofemoral delay. Blood pressure is 124 by 86 millimeters mercury, measured in left arm supine position. Respiratory rate 18 per minute. She was afebrile to touch at the time of examination. These are the clinical images, sir. Local examination. After taking informed consent, patient is examined in sitting position with me sitting in front of the patient at the same level in a well-lit room. On inspection, a globular swelling of size about 4 into 3 centimeter situated in the thyroid region towards the left side. Swelling is moves with deglutition. Lower border of swelling visible on swallowing. Swelling has smooth surface with well-defined margins. Skin over swelling is normal. No scars, sinuses, pigmentation, and visible pulsations were seen. No dilated veins over neck and upper chest. Trachea appears to be in midline. Extent of the swelling: superior border 2 cm from the thyroid cartilage, and inferior border 1 cm from sternal notch. Left lateral border, anterior border of left sternocleidomastoid, and medially swelling crosses about midline about 1 cm to right side. Right lateral border 2 cm medial to anterior border of right sternocleidomastoid. And palpation: patient is examined in sitting position by classical method and standing behind the patient in a classical method. There was no local rise of temperature, no tenderness. All inspectory findings of size, shape, surface are confirmed by palpation. Both lobes of thyroid and isthmus are enlarged with nodular surface and well-defined palpable inferior border. Largest nodule measuring 4 cm into 3.6 cm, vertically oval, palpated in left lobe with well-defined borders, nodular surface, and firm in consistency. Swelling moves with the deglutition. Spleen of swelling is deep to deep fascia and strap muscles. Trachea is palpated in midline. Carotid artery pulsations are present at palpated normal position. No palpable thrill at superior pole of thyroid. No palpable cervical lymph nodes noted. On percussion over magnum sternum is resonant. Auscultation: breath sounds heard in midline, confirmed. No audible brood near upper pole. Systemic examination: CVS S1 S2 heard, no murmurs. Respiratory system: normal vesicular bed sounds, no added sounds. CNS: normal mentation and intelligence, no anxiety and no tremors. No focal neurological deficits were seen. Parabdomen: soft bowel sounds present, no enlarged spleen or liver clinically. Musculoskeletal system: no proximal myopathy, no bony lesions, no bone pain. Examination of scalp was normal. To summarize my case, a 42-year-old lady, 42-year age lady, presented with painless swelling in front of the neck for the past 2 years, with which is insidious in onset, gradually progressive, and with no pressure symptoms. Patient clinically appears to be in euthyroid state and no other systemic symptoms. On examination, general survey and systemic examination is normal. Both lobes of thyroid and thyroid isthmus are enlarged with a nodular surface and well-defined palpable inferior borders. Largest nodule measuring 4 cm into 3.6 cm, vertically oval swelling, is palpated in left lobe with well-defined borders. Surface of swelling is nodular and firm in consistency. Swelling moves with deglutition and does not move with protrusion of tongue, without any features of compression, fixity, retrosternal extension, and no palpable cervical lymph nodes. They said bilateral asymmetrical, most probably benign thyroid swelling. My provisional diagnosis is non-toxic, non-malignant multinodular goiter with a dominant nodule in left lobe in clinical euthyroid state.
Dr. Ganesh, only 2-3 clarifications. Having seen the lower border of the swelling, why should you percuss the sternum? Number 1. Number 2, on inspection, you made out the swelling margins, but on palpation, you mentioned it as borders. It is better to commit borders for the swelling, margins for the ulcer, right?
Okay.
And you first answer that question, first question. Why should you percuss the sternum having seen the lower limit of the swelling?
Sir, there is a entity called plunging goiter, sir. So sometimes there may be swelling in the thyroid region may be small, but there may be plunging goiter.
In this case, you are suspecting plunging goiter?
No, sir.
Then?
He was already seen on inspection lower border.
Sir.
Then you are expecting a plunging, you will have the lower border can be seen?
No, sir.
Once you see the lower border, that rules out retrosternal goiters. So no need of percussion, no need of doing all these maneuvers. Okay. When you don't see, probably it is required. That's what the message is. Okay. Now we will go back to your inspection slide, palpation inspection.
Sir, I like to add a thing. If you have mentioned, you can say that just to rule out the nodes in mediastinum, or sometimes there can be an ectopic thyroid, that too usually in a larger goiter.
Larger.
Just to justify when you have percussed, right?
Okay.
Yes, sir.
Yeah, you have very clearly said the lower border is visible and swallowing. Okay, go to the next slide. Yeah. Yes. Next slide. You very clearly mentioned the lower border. Yes.
Yes.
Next slide. Yes. Yes. Next slide. Yes. Yes. What is the differential diagnosis you offer in this patient?
Sir, colloid nodular goiter, follicular adenoma, thyroiditis, Hashimoto's thyroiditis, and to rule out carcinoma thyroid.
I think before we go on the differential diagnosis, I would like to ask certain questions.
Yes, sir.
At one place, you have written no tongue. What does that
Sorry,
mean?
it was a mistake, sir. I meant macroglassia.
Okay. Now, if you say it is a no tongue, can you tell what is no thyroid?
Sir,
What is-
Sir, athyrogenesis, sir. Athyriosis.
Athyriosis, yes. No, that is all. Then in your pulse examination, you said about the radio-radial and the radio-femoral delay. Why did you do this in this patient? In the examination, the pulse?
Sir, startup.
Oh.
There are so many things which are the part of that, but you have to know the relevance of that. Whenever you are doing committing anything at the postgraduate level, you have to know the relevance of that. What is the relevance of carrying out a radio-radial and the radio-femoral delay?
Yes, sir, I understand.
There are so many things which you have to describe in the pulse examination. Okay, in the thyroid, there are 25 eye signs there, which you have to, but you will not describe all those things. No?
Yes.
So there is no relevance of radio-radial or the radio-femoral delay in this patient. Okay, until unless you are suspecting some stenosis is there, or coarctation of aorta is there, subclavian artery stenosis is there, all those things are there, then you will think about that.
Okay, sir.
Then on inspection, you said the trachea is in midline. Can you tell on inspection that the trachea is shifted?
Yes, sir. By means of trial sensor, there will be prominence of sternocleidomastoid to the side of tracheal deviations.
Right. Okay. Now tell what are the different types of the retrosternal goiters? You know, we were discussing about the lower border, and
yes, sir.
Yeah. So what are the various types of the retrosternal goiters?
Sir, one is a plunging goiter, sir. Another plunging goiter, retrosternal goiter. Primary goiter, maybe primary goiter is ectopic, arises from ectopic thyroid, sir.
So it can be substernal variety, it can be intrathoracic variety, it can be plunging variety.
Yes.
Okay. Can it go to the posterior mediastinum?
Sir, no, sir.
7 to 8% of retrosternal goiter can be in the posterior mediastinum.
Okay.
So that is the one indication of doing a sternotomy for doing a.
Ganesh, you mentioned in your final comment there is no fixity, but in your clinical palpatory findings you have not mentioned anything about intrinsic mobility. How will you know there is no fixity without testing the intrinsic mobility? How will you say?
Sir, I have tested, sir, but I forgot to add in the.
Okay. How will you test the intrinsic mobility in a multinodular goiter?
Sir, it is for a small swelling in a thyroid, sir. We can use Kryle's method of palpation.
You stand behind the patient, slightly extending the neck, put your finger in the lower part of the swelling, try to lift it. If it is a benign swelling, it will very well go up and come down. Whereas if it is a malignant one, you will not be able to move it, right?
Yes, sir.
But testing the horizontal mobility is a little difficult. You have to fix the trachea with one hand and then individually you must try to move it. But testing the vertical mobility is more significant. That is a way of testing the intrinsic mobility. Right? Okay.
Ganesh, can you show the slide in which you have written deep to the deep fascia, that one slide? I just want all of you to know that please tell deep to pretracheal fascia. Okay. See, somewhere you have written there. Yeah, just hold on. See, in your case sheet, you are not supposed to write like this. You have to only say that swelling moves with the deglutition. That's all. Let the examiner ask you what is the meaning of the word swelling moves with the deglutition. Then you are going to tell that all the swellings which are deep in the pretracheal fascia move with the deglutition. Then the next question will come is, what are the swellings which move up with the deglutition? Is it clear?
Yes, sir.
So it is not necessary. Don't say deep to deep fascia. The examiner asks you, your answer should be deep to pretracheal fascia. And it is understood it will be deep to strap muscles. You don't have to mention that separately. I hope it's clear. Okay?
Okay, sir.
Dr. Ganesh?
Sir.
Do you identify test for the strap muscle? Can you do the testing?
Sir, we ask the patient to extend the neck. With the extended, I ask the patient to open the mouth and reverse the tongue and touch the hard palate, sir.
Extension of the neck is a function of the strap muscle?
No, sir, we will ask the patient to reverse the tongue and touch the hard palate, sir. Making the doing this maneuver causes the strap muscle contraction.
It's very difficult to demonstrate, and it is not. I'm not sure, but other examiners out.
Sir, it is not relevant, sir, that is touching this strap muscles and all that. Just have to mention that swelling which moves up with the deglutition, they are all deep to the pretracheal fascia. Over. I think not.
Yes, sir.
Controversy.
Only needed that.
1 point, sir.
The pretracheal fascia. And you also said it's a vertically oval. It's a bilateral swelling, but it is vertically oval. That is something strange.
Sir, actually entire thyroid is enlarged, sir. By bilaterally, I meant entire thyroid is enlarged.
Right. When both the lobes are involved, whether it looks like a vertically oval?
Sir, the largest nodule is vertically oval. Sir.
No, you are not mentioned like that. You have said that a swelling is vertically oval.
I mentioned.
Yes, mentioned as largest nodule, sir.
Apurva Shah, sir, you wanted to add something, sir?
Yeah.
Yes.
One very simple and basic thing. Ganesh, you have to understand one thing. This is a Zoom class, and so you are able to go up to diagnosis. I am very sure the way you have described the history and the general examination, probably in exams, you would not even clear your local examination. Don't try to fill up everything that you know in the history part. Let the examiners ask you what you are trying to say and what you are trying to see. Don't try to look for macroglacia and don't try to, you can say tremors in the hand, but that should be separate thing when it comes to a case of thyroid. Don't try to complicate the history so much that you cannot reach up to the diagnosis.
Yeah, Dr. Ganesh?
Sir.
In relation to the sternocleidomastoid,
You have.
what is the relation of your swelling to the sternocleidomastoid?
Sir?
What is the relation of this swelling with sternocleidomastoid?
Sir, the swelling is the swelling is medial to the left sternocleidomastoid. Largest swelling, the largest nodule palpated is 2 centimeter, 1 centimeter medial to the left sternocleidomastoid.
So you want to say that nothing is going in relation to the sternocleidomastoid here?
The plane of swelling to sternocleidomastoid. How do you test for STM?
Right.
You know, if you have not even done the test, you can blindly tell me that it is deep to the sternocleidomastoid.
Yes, sir. Yes, sir.
Whatever the size of the goiter may
In fact,
be.
you've written it also. You've written it.
It may be
Plane of
huge
swelling
goiter.
is deep.
It may be huge goiter, but it will never come superficial to the sternocleidomastoid.
Yes, sir,
So you can
because
blindly say that it is deep to the sternocleidomastoid. Okay.
Yes.
Dr. Hemant sir, I could see your hand up.
Yeah, Dr. Ganesh, you demonstrated the test. There is no swelling movement on protrusion of the tongue. Why you have done this test in this case?
Sir,
when on the examination you have seen that it is a multinodular. From the history clinical examination, it looks like a thyroid. Why did you go for this test?
Sir, thyroglossal cyst.
Thyroglossal cyst is the midline and in the upper part of the neck.
Upper part. Sir.
So this test is not warranted in this case when you have already examined. There are multiple nodules, both sides of the neck. Okay. So this test may not be required. Right?
Ganesh, may I ask you a question? Suppose it was a very large thyroid where you cannot palpate the trachea. Is there any other way of finding out whether the trachea is placed or not?
Sir, we can auscultate the tracheal positions.
Right. Auscultation. So that's a better method.
Another way is extra.
Okay. Did you test for the proximal muscle weakness?
Yes, sir. But in this patient, actually, per se it is not required, sir, because she doesn't have any hypothyroid symptoms.
How do you test for it? That's a question.
We'll ask standing up from a sitting position, sir, and another one is lifting weights, sir, like bucket of water. If she is having any difficulty in lifting a bucket of water, or standing up from Indian
the best way is to
squatting
take
position.
in history whether she has difficulty in standing up from the toilet, Indian type of toilet.
Okay. He doesn't have any difficulty in standing up from squatting positions.
Rana sir.
You know, like one or two quick suggestion and one or two quick observation. As I was saying in the history taking, quick suggestion is that, you know, like you must again remember not the all 23 eye signs, but few important eye signs you must remember. You must keep on practicing, because in the examination of thyroid, the examiner will ask you to demonstrate one or two clinical signs definitely on the patient. So, you know, like just keep on practicing that, and same as the eye signs, you know, at least you must remember a few of them. So that was a quick suggestion. Now, when you are describing the clinical finding, you should not describe with extreme precision, because if you describe with extreme precision, examiners start looking at you with jaundiced eye. What am I trying to say? Like both the lobes are palpable and isthmus is also palpable. That is too much of precision. Most people, most examiners will be satisfied that both the lobes are enlarged, maybe right more than left or whatever. Isthmus, only if there is a nodule definitely arising from the isthmus, then you can say. That's one. And then another thing, when you talked about the size of the swelling, the size of the swelling is 4 into 3 centimeter, and the size of the largest nodule is 4 into 3 centimeter. So that's a kind of, again, a mismatch. Either the whole swelling is only one node, because, you know, like both of them are absolutely same. So that was another thing. And third thing, like at 3 places you were caught unaware by the examiners. Why did you percuss the manubrium sterni? Why we were looking for the radial or radiofemoral delay? Why did you, you know, demonstrated or asked for the protrusion of the tongue for a lateral swelling? You can, you know, like you will always have one external and one internal in the examination. Usually internals, they err towards the size of their students. So if you were stuck in a situation like this, one very simple answer will be, sir, just to complete the examination. That is how I have been taught, that any thyroid swelling, just to complete the examination, I must percuss the, like the manubrium sterni, or while I am describing the pulse rate, I must talk about the radial femoral delay. And then if the examiner tries to push you to a corner, that is the time when the internal will come into the, no, sir, we have taught them just for the completion of the examination. So that's another way of explicating, from this difficulty. Otherwise, you will find it really very difficult. And then once you become nervous in the examination, then that is where the problem starts. So in a situation like this, that's just to complete the, for the completion of the examination. That is how I have been taught. And I am sure internal will jump into it. That's all. Thank you.
Okay. Shall we proceed, sir?
Yeah.
Yes.
Lastly, Ganesh, just for the completion's sake, just enumerate the important eye signs.
Sir, yes, sir. Pulmonary traction, red sir, and Shellback sign, Von Graffis sign, Dahl-Impel sign, Geoffroy's, Mobius, and Jelinek signs.
Okay. What is Jelinek sign?
Sir, pigmentation around eye, sir. Pigmentation.
What type of pigmentation? What type of pigmentation?
Sir, dark pigmentation.
Yes. Yeah, hyperpigmentation. Mention that. Yeah, correct. Yeah, go ahead. Now let's continue.
Having made a diagnosis of non-malignant, non-toxic MNG, how are you going to proceed with this case?
Sir, this is a provisional diagnosis. I will like to confirm my diagnosis with further investigation, sir. I will use ultrasound thyroid, and because there is a nodule already seen in clinically, I will go for ultrasound guided FNAC also. Based on the results, I will move further, sir.
What is the role of ultrasound?
Sir, ultrasound we can see the anatomy, sir. Lesions also, architecture of the lesions. In case of nodules, we can see for features of malignancy like hypo or hyperechogenicity, vascularity, any microcalcifications, or any cystic components, and these features can be identified from the ultrasounds.
Impalpable nodes also can be picked up.
Yes, sir. Impalpable nodes also, sir.
Dr. Prasad, sir, I have one small doubt. Ganesh,
sir,
what made you to use that word dominant nodule in your case? Is it because of the size you made a diagnosis of dominant nodule, or what?
Sir, when I palpated, sir, the nodule was the biggest one, but the rest of the thyroid was also nodular, sir.
Just a minute. So if there's a big nodule, you call it as a dominant nodule? Is
so
that
no, sir. No, sir.
So you said patient has multiple nodules, correct?
Yes, sir.
Then why get into trouble? Simple diagnosis. See, don't get into trouble. Dominant nodule does not mean the size. For all that matter, that big nodule may not be malignant. There could be another nodule which is firm or hard, can be malignant. So don't get into trouble. That's all. Okay. I just want to tell you that. My diagnosis is simple, non-toxic, whatever you will, multinodular goiter. That's all.
Okay.
Yes.
And before going for ultrasound, will you do thyroid function tests and all?
Yes, sir.
To confirm your clinical diagnosis of euthyroidism.
Yes, sir. We can do TSH, sir. If TSH is normal, that means there is no hypo or hyperthyroidism.
So you'll go with the thyroid function test first, and then you will go for ultrasound, then FNAC. Am I right?
Yes, sir.
Right.
Why only TSH, Ganesh? You said only TSH.
Sir, she is TSH is a screening test, sir. We can easily diagnose with a single test alone. We can easily diagnose hypo or hyperthyroidism. If there is a hypo, we can go for T3, T4, TSH.
So what happens in Hashimoto's? How do they become hyper and hypo with a normal TSH?
Sir, in Hashimoto's thyroiditis, there is a autoantibodies are present, sir, anti-TPO antibodies. Initially, there will be thyroid hyperplasia, which causes.
Why?
Sir?
Why? Why will there be hyperthyroidism? That's what I'm asking.
Sir,
See,
inflammation.
TSH, yes. Yes.
Inflammation.
No, not inflammation. What happens?
Hypervascularity, sir. More increased blood flow.
TSH is normal. Why there is hyperplasia? With the TSH normal, why do you are getting the hyperplasia?
Understand the question, Ganesh.
Sir, antibodies are taking up the role of TSH.
MNC, multinodular.
No.
Antibodies. Here there is no antibodies there.
Yes, sir.
No, if there is TSH is not increasing to stimulate that, anything else can happen. The particular cell can hyper response to the normal stimulus. There are subset of thyroid follicles which responds with more. With the same TSH level, the response from them is more.
Okay, sir. Okay, sir.
Yeah, I think he told about FNAC. Can you tell us more about what all things you see on FNAC? What are the various types? Can you tell us that quickly? Ganesh?
Yes, sir.
What is FNAC? What is FNNAC?
Sir, FNAC stands for fine needle aspiration cytology, sir, and FNNAC stands for non-aspiration cytology.
So where do you do that? Where do you do that?
Sir, FNNAC is better than in thyroid also. In thyroid, FNNAC is better, sir.
Okay.
So we use 23 to 24 gauge, 27 gauge needle. Capillary or suction technique we will use.
In which swellings you don't do FNAC in the thyroid swelling?
Sir, anaplastic if you are suspecting anaplastic carcinoma.
No.
FNAC will not be swelling.
Contraindication for FNAC in thyroid.
Thyrotoxicosis, sir.
Said to you.
Thyrotoxicosis.
Yes, thyrotoxicosis. And clinically, whenever you palpate a thrill or bruit, when you hear a bruit, you're not supposed to do an FNAC, mind you that. And then FNAC, where else you don't do as a first level of investigation? We are only talking about FNAC now. Then we'll go to the next step of investigation. So one, you said that in a thyrotoxicosis patient. Second, whenever you hear a bruit or a thrill, you appreciate a thrill, you don't do that. So agree.
Yes,
next.
Ultrasound, if it's follicular adenoma, FNAC has no use, sir.
No, we are not talking about the limitations of FNAC. We are talking about FNAC not being the first choice of investigation. In which condition? Where you are suspecting to do another investigation probably ahead of FNAC. What is the reason for that?
Sir, Riedl's thyroiditis.
What is the reason?
Ganesh, supposing the patient is primary thyrotoxicosis.
Yes, sir.
Would you go for an FNAC?
No, sir.
No, he has told that, sir. He has told that. Yeah. I think
Okay.
the next would be FNAC should not be done in a patient where you want to do a thyroid scan to rule out malignancy, because FNAC will cause hemorrhage and produce a nodule which looks like a cold nodule.
Like a cold nodule.
So you should avoid. So there probably a scan would be a first preference, and then go for an FNAC. So these are the limitations of FNAC and FNNAC. What is the next level of investigation you want to do?
So again, sir, a few more questions on the FNAC itself, sir.
Yes, sir.
Which
Yes, sir.
nodule you will prefer to have FNAC, from larger nodule or smaller nodule?
Sir, have sir, for a less than 1 centimeter nodule, if the patient is having any history of irradiation, family history or previous history of carcinoma, cancers, we have to go for FNAC, sir. For a nodule of 1 centimeter size with high risk features in ultrasound, we have to do FNAC, sir. For intermediate risk nodule of 1.5 centimeter, again you have to do an FNAC. For a low risk nodule of more than 2 centimeter, then you have to do FNAC, sir.
You'll do FNAC in all cases with ultrasound guide or with a naked eye?
Sir, ultrasound guided is preferable, sir, as many vital structures are located in the same.
So in all cases, you'll do only ultrasound guided FNAC.
Yes, sir.
Or is there any selective indications? You should go for ultrasound guided FNAC.
Sir, I don't know, sir.
Actually, when the nodule is very deep, posteriorly placed, or very close to the major vascular structures like IJV or carotid artery, or repeatedly our naked eye FNAC 3 times or 4 times it is negative, in that or impalpable nodule, in those situations you must use ultrasound as a guide, right?
Yes, sir. Okay, sir.
Not routinely in all cases.
Yeah, Ganesh,
can you say something? Sorry, sir. Can you say something about ultrasound in thyroids? Any specific? What does Thyroid stand for?
Thyroid stands for Thyroid Imaging Reporting and Database System, sir. It uses ultrasonographical features to grade the thyroid lesions, sir. Thyroid
so what is a grade?
Thyroid
Yes.
Thyroid 1 is non-diagnostic. Thyroid 2 is benign lesion. Thyroid 3 is benign. Thyroid 4 again is suspicious of malignancy, sir. And thyroid 4 again is divided into 4A, 4B, and 4C based on the number of suspicious features present, sir. And the thyroid 5 is malignant, sir.
Okay, great.
Thyroid 6 is non-diagnostic.
Yeah.
Yeah. Well,
6 is
Ganesh,
proven malignancy.
Ganesh,
sir.
On FNAC, the interpretation is given as BSRTC grade 3. What do you mean by that?
BSRTC grade 3, sir.
Yes. What is BSRTC?
Bethesda system of reporting thyroid cytology, sir.
Okay. Cytopathology. Okay. It's
sir,
not cytology, cytopathology. Okay.
Cytopathology, sir. Yes, sir.
Yeah. Okay.
BSRTC 3 means it is a ATP of undetermined significance or follicular lesion of undetermined significance.
So correct. So what would next?
When do you say it is non-diagnostic?
Sir, sir, aspirate should be containing more than 6 follicles. And sorry, sir, I couldn't remember.
Groups of follicular cells, each having 15 to 20 cells in 2 aspirates. That is the definition of non-diagnostic, right?
Yes, sir. Yes.
Go ahead.
What is the frequency of the probe which is used for the ultrasound of the thyroid?
Sir, 7.5 to 16 megahertz, sir.
7.5 to?
7.5 to 16 megahertz.
16. Okay. When you do abdominal ultrasound, then what is the frequency?
Sir, it is low frequency probe, sir. Less. I don't know the.
You have to say linear probe or sector probe first, and then megahertz. Okay. Yeah.
3.5 to 5 megahertz. You know? For the abdominal one, it is 3.5 to 5.
Yeah.
Ganesh, apart from the nodule, what is the biggest advantage of the thyroid ultrasound?
Sir, can you repeat the question, sir? I couldn't hear it.
What is the biggest advantage of the ultrasound in thyroid gland other than looking for the thyroid gland?
Sir, we can see for lymph nodes, sir.
So which lymph nodes? Very important. Yes. Which lymph nodes?
Sir, central compartment lymph nodes, sir. Level 6.
Central is very easy. No, you can also feel here. What is more important? What is the
lateral compartments?
Don't say lateral. See,
level 2, 3, and 4.
Level.
Always use the proper words. Say they are all along the jugular vein. So 2, 3, 4. That is how easy to remember. Okay. Jugular chain, which is sometimes very difficult to feel, so that you can always pick up with the ultrasound, right? And also vascularity, right? Taller than wide, taller than wide.
I think you mentioned, sir.
Okay, thank you. Yes.
Yes, sir. Rana, sir.
What is the typical microscopic picture of papillary thyroid carcinoma?
Sir, we see papillary patterns, sir, and The diagnostic features are intranuclear inclusion bodies with nuclear grooving, sir, and orphan anide nucleus.
What about
And
the
some of
cytoplasm?
bodies. A cytoplasm is intensely eosinophilic with inclusion bodies, sir.
What is the treatment for this patient? You've done everything. Suppose it's a multinodular goiter. What's the treatment for this patient?
Sir, multinodular, what is the treatment? This question, sir.
Yeah, in this patient, how will you manage?
For options. What are the treatment options?
Sir, multinodular goiter is an irreversible disease. I would like to go for surgery, sir.
Why can't you do? Can you do conservative management here?
No, sir. No role of medical management.
Suppose she was in puberty. Suppose she was a pubertal girl. Then what would you have done?
Sir, follow up, sir.
No follow up. You won't do anything. Give her anything. Why? What is the basic pathology of multinodular goiter?
Sir, MNG develops due to variation in the response of follicles.
Fluctuation of TSH. Fluctuation of TSH. Okay. Yes, so sir. in such young girls, you cannot go in for surgery straight away.
Yes, sir. We
so you have to give
supplementation, sir.
Yes.
You have to give so that TSH levels remain stable, sir.
Yes, you have to give a supplemental level. And how much is that? How much is that?
100 micrograms, sir.
Huh?
100 micrograms per day.
Okay, 100 to 200 micrograms. That's it.
Sir, you wanted to ask something?
So, can you get a primary thyrotoxicosis in the multinodular goiter?
Primary toxicosis. Sir, it will be secondary. It will be called as secondary thyrotoxicosis.
If there is hypertrophy of the internodular tissue, so that is the only functioning tissue will be there. If that particular internodular tissue is going for the toxicity, it can produce primary thyrotoxic symptoms. When the nodular is converted into the activity to the that, it only produces a secondary thing.
Yes, sir. I cannot.
Rana sir, you wanted to tell something, sir?
Yeah, two very quick points. One point I wanted to say earlier, which I forgot. When Ganesh was talking about the provisional diagnosis, all the things which he said that it's a non-malignant thyroid enlargement. In a multinodular goiter, to say dogmatically that it is not malignant is not a very prudent thing to do. That should have been omitted. I wanted to bring this before. And second, when you are asked that why will you do ultrasound guided FNSE, the answer is very simple. I mean, like that to avoid sampling error. Like what do you mean by that? You can say that we can, I mean, if I have to stick a needle to take the sample, I'll focus, like my needle onto an area which is heteroechoic. So, I mean, that's a practical tip. And as I am saying that you have got an internal by your side, and whenever you are in difficulty, and internal is moral bound to come to your rescue. So, and that's all. Thank you.
Ganesh, one question I would just like to ask you. You said surgery. What kind of surgery will you do for this patient? And why?
She's a 42-year-old female, sir. I would like to do near total thyroidectomy.
Why near total? Why not total?
Sir, we can avoid lifelong supplementation of thyroxines.
So you think near total, she will not require supplementation? What are the indications for doing total, and what are the indications for doing near total?
Sir, in malignancies, we have to do near total.
Can this turn malignant later on?
Yes, sir. There is a risk of malignancy.
So?
Total thyroidectomy, sir.
Okay. Suppose you've done total thyroid, then how will you follow her?
Sir?
How will you follow up this patient?
After total thyroidectomy. Sir, we have to give supplementation dose of thyroxine, sir, and every 6 months we have to thyroid function test. Based on the TSH levels, we have to adjust
Right.
the dose.
So don't beat around the bush. Just say TSH. TSH and thyroglobulin. These are the two things you have to test.
Yes.
Right.
Yeah, Ganesh, I think total thyroidectomy is the correct surgical procedure in the current vogue. Now that you want to do surgical approach, surgical treatment for a multinodular goiter, total thyroidectomy, what are the options you've got now, the current days of practice? Lastly, there's about 5 minutes more. We'll finish the recent advances also. Tell me.
Sir,
What are the surgical options we have got today in the current day of practice? Total thyroidectomy is the surgical procedure. How do you plan to do it?
So we can do open thyroidectomy, sir. The other approaches are endoscopic approaches, sir. Bilateral axillobreast approach, through oral approach, and another one is facelift approach.
So what do you know about this minimal access thyroid surgeries, MATS? Tell us something about that. We know about open thyroid surgery. You have prepared very well, agreed. And I think Rana sir also will agree with me. Tell us something about minimal access thyroid surgeries today. What is MATS? What is MITS? What is MEATS? Who started this? When did it start? How many years old? What are the current advantages, disadvantages? Please tell us. 5 minutes I'll give you. Please tell us about all the recent advances about thyroid surgery now. As a final year postgraduate, definitely you are supposed to tell us. Yes.
Sir, bilateral axillobreast approach was started in South Korea. Sir, I don't know much.
Usher et al. Yes, he started in 1997. So it's almost 24 years plus these surgeries. Yes. Then?
Sir, we don't use any gas in the surgery, sir.
Yes, they are called gasless thyroid
gasless.
Yes,
and specialized endoscopic instruments are required.
Yes. What are the advantages of this minimal access thyroid surgeries?
Sir, cosmetic, mainly cosmetic, sir.
Mainly cosmetic. Pain is less.
Pain is less.
Pain is less. Complications are less. That's what it means. Okay. And there is no scar in the neck.
Sir.
Okay. That's good. Rana sir, I think you can summarize.
Only one question, sir. Last question. What are the two important dreaded complications you'll encounter commonly in thyroid surgery? How will you avoid them?
So one is hemorrhage, sir. Another one is recurrent laryngeal nerve injuries.
You will preserve all 4 parathyroids in all thyroid surgery safely.
No, sir. That is also.
Yeah, I am much worried about that only. How will you avoid injury to parathyroid during thyroid surgery?
Sir, we have to do sharp dissection near parathyroid, sir. We should identify parathyroid by means of superior parathyroid is posterior to RLN and inferior parathyroid is anterior to RLN, sir. There is a sentinel pad of fat just beneath the superior pole, sir. And parathyroid is identified by means of golden yellow color with plexus of vessels over it, sir.
Which is more prone for ectopic locations?
Sir?
Which is more prone for ectopic locations, superior or inferior?
Inferior, sir.
Why?
Sir, inferior descends from inferior originates from third pharyngeal fold, sir, and it descends along with the
long descent.
Long descent, yes.
When compared to superior one, it has got a long descent. That is why it is more prone for ectopic locations.
Yes.
Right. Suppose accidentally injured, a bit of thyroid, parathyroid is seen along with the thyroid specimen. What will you do that?
So we have to keep it in freeze saline and mince it, sir, 2 pieces of 1 millimeter, and we can place them auto transplant them in sternocleidomastoid or non-dominant brachioradialis muscles.
Okay. Good.
Rana sir, please.
Ganesh, habits die hard. In spite of one of the examiner telling you right in the beginning that, avoid using, 42-year-old You persisted with 42-year-old, so let it be 42-year young. That was one. I mean, and you will have to practice it, believe me, if you can. Unless you practice during your ward rounds, you'll be, like doing the same thing over and over, again and again. Second point, unless you are absolutely sure that Professor C.R.K. Prasad is your examiner, when they ask you what is the surgical treatment, don't start with the minimal access surgery. Otherwise, you will be in a soup.
Agreed.
That's point number 2. 3, few of the complications. This is for all these students who are attached of thyroid surgery. You'll have to read, jot down, remember, be prepared to reproduce them in the examination, like thyroid storm, tracheomalacia, recurrent laryngeal nerve injury, unilateral, bilateral. The examiner will ask you, like, what if happens? What will you do? What will be the problem? How will you diagnose? How will you treat? And severe hypoparathyroidism. So all these complications, there are many more. Probably these are important complications which all these students should prepare now to answer them in the examination, because as I said, you can't pass masters without confronting thyroid. And when the thyroid surgery comes into the picture, you will be asked about all these complications. And that's all I have to say. Thank you so much.
Professor Apurva Shah, sir, please.
No, absolutely fine. Ganesh, one more thing. When you have operated a total thyroidectomy, what would you tell to your junior to look after when the patient reaches the ward? Only one question.
Sir, we have to look for any respiratory distress, sir, and swelling over the neck, sir, tense swelling over the neck with ecchymosis. There is chance of a reactionary hemorrhage.
Yes. So as soon as if you feel like, just open up the stitches. That is the most important thing. Right. Okay. Well prepared. I think you were over prepared, but the thing is, keep it simple. That is my advice. Everybody has said this thing. Please keep it as simple as possible.
Okay, sir. Thank you, sir.
Yes, sir.
Thank you, dear faculty.
Thank you. Thank you.
I would like to thank Dr. Ganesh for
thank you.
Definitely keeping cool with all the questions. We normally give the candidate a chance to ask questions or any doubts to the faculty here. Dr. Ganesh, with so much of theory and so much of practical knowledge which you have gained over so many years, I'm sure you will have a lot of questions which have come up in your mind. What do you think is the most important question you would prefer to clarify at this point of time?
I don't
feel free to do that. This is the privilege we give to the students who have taken all the pains to prepare and present.
Sir, I have always faced difficulty with identifying RLN only, sir. Even though with all the identifying features.
Maybe I will request Rana sir to give a short 1 minute note on RLN, sir, please. Rana sir, please.
I think there are practical tips written in the textbooks, how to identify recurrent laryngeal nerve during surgery. It lies in the tracheoesophageal groove. It runs vertically. But I think the most important practical tip is to get involved in thyroid surgery repeatedly. This is something, it's a very, it cannot be learned, very in a short span of time. So, and another very important thing, another very practical tip is, like when we are talking about the total thyroidectomy or subtotal or near total, multinodular goiter, as of today, probably the standard of care is total thyroidectomy, provided you know how to do a safe total thyroidectomy. Because this operation is easier said than done, because it is confronted with so much of complications, and one of the most important complications is the injury to the recurrent laryngeal nerve. So just to avoid the injury to the recurrent laryngeal nerve, there was a dictum when I was training: don't see it, you will be safe. Gone are the days. We want to preserve the integrity of an anatomical structure in the surgical field. The only way you can be absolutely sure is demonstrate this structure into the operation field and safeguard it. So that is another very important thing, that don't practice or don't learn the slipshod thyroid surgery like near total, subtotal, because if you identify it in all cases, you will be able to safeguard it in the most difficult cases. But suppose if you are, trying to err towards the near total or subtotal in an attempt that, why should I identify the recurrent laryngeal nerve? At least for the malignancy, you will have to do total thyroidectomy. And at that point of time, you will find it nearly impossible to identify this structure in the field. So that's all I can say. And needless to say, extremely important to preserve its anatomical integrity during thyroid surgery.
Sir, can I add one thing? For beginners, don't be afraid of bleeding in thyroid. If any bleeding occurs, unless and until you have identified the nerve, don't cauterize, don't tie, just try to control it by other measures before securing that bleeder.
The point is well taken, sir.
Can I add something?
Yes, Shanai sir, please, sir, please.
Just adding on to all the things. Again, when we were students, subtotal was the most common operation which we have seen. So obviously, there's hardly any chance the recurrent laryngeal nerve also. Adding on to what Ganesh's question of Ganesh, you will realize it only when you again start doing it and start assisting. But standard procedure of a middle thyroid vein is ligated. Then you go up to the superior pole. There also artery and vein you ligate separately nowadays, not as together. Inferior thyroid, you find some few veins there, ligate them. Then you start mobilizing the lobe. The time. As you are almost getting mobilized lobe to the other side, you can see that really getting tethered there by so-called the Beris ligament area. That's the condensation of the petechial. This is the place where you need to identify inferior thyroid artery by pulsations. Once you identify that their branches are there, now individually, if you can ligate those 3 or 4 branches, that is the time you can see the nerve. Right side it is little far away. Left side it is very close to the groove. So that is the place where you can see it is entering into the cricothyroid joint. So the crucial points are some disturbance, identifying the branches of the inferior thyroid artery. One, putting the lobe to the other side and getting tethering. That is why if you are not very competent in this patient, for example, if she comes to you, you start doing the left total and at least the right so-called the subtotal or a Dunhill. That is the reason, because at least you are sure that you have preserved one nerve and some para. That's all, sir, my comments.
I think what Shanai sir said is very true. Try to trace the branches of inferior thyroid artery and ligate them 3-4 in number. Probably would save blood supply to the parathyroid also, and also you are also saving the recurrent laryngeal nerve. I think that is the message today. Earlier, we used to ligate away from the gland in continuity was the earlier concept. The current concept is, yes, identify the 3 or 4 branches of inferior thyroid artery and ligate them close to the gland after due dissection with due preservation of recurrent laryngeal nerve. Well said, Shanai sir. Well summarized.
I think at this point, we should remember 2 words which are there. One is the Zucker candle.
Yes.
That is the Zucker candle tubercle, which is there. That is a site where there is a maximum chance of injury to the recurrent laryngeal nerve. So you have to take all care at that point that you do not damage that. And another, you have to know about what is called a capsular dissection. This is called as capsular dissection, where you are not ligating the main artery, but you are just working over the capsule of the thyroid to take care of that, to take care of the recurrent laryngeal nerve, as well as to take care of the parathyroids. Yes, because all parathyroids are supplied by the inferior thyroid artery. So you have to take care of that. That is why you are doing the capsular dissection.
Thank you, sir. Any other question, Dr. Ganesh Reddy?
No, sir.
Thank you, Ganesh Reddy. I think on behalf of all the faculty, I wish you good luck and you did well. Only thing, it comes by repeatedly presenting and repeatedly fine-tuning your presentations and case sheet writing. Ensure you write every single case sheet, even if your juniors have written. Time it and write the case sheet, because exam is time. Rana sir very clearly pointed out, time is the essence in exam. And none of the investigations are going to be shown unless the examiner would like to inform you about some investigations. So being a class, it is okay. But then the time limit of examination, which is given to you during the exam, should be very much taken into consideration. With these few words, now I would like to move on to the next case with the permission of the faculty. I warmly welcome the BJMC team. I could see Professor Jayesh Parekh sir also joining up. And we have Dr. Shweta Sutar from BJMC to start a presentation on chronic ulcer of the foot. Over to you, Dr. Shweta.
Good evening, everyone. Good evening, everyone. I'm going to present a case on ulcer under guidance of my PG teacher, Dr. Pankaj Modi sir, professor and head of unit, under guidance of Dr. Maulik Mehta sir, assistant professor, Dr. Hardik Bhatt sir, assistant professor, Dr. Prujal Parekh, assistant professor. I would like to go. Presentation: 51-year Hindu male patient residing at Ahmedabad, a rickshaw driver belonging to lower socio-economic class, presented with chief complaints of raw area over left foot since 1 month. History of presenting illness. Patient was relatively asymptomatic 1.5 months ago. Then he had history of tibial trauma over left foot, and on the next day he noticed swelling over the left foot associated with pain for 3 days and foul-smelling discharge for 2 days, for which debridement was done outside. Wound was regularly cleaned and dressed, and patient was referred to higher center for further wound management. There is no history of purulent discharge from the raw area, no history of scanty discharge from the raw area, no history of fever, no history of intermittent claudication or rest pain. Past history: patient is known case of diabetes mellitus since 2 years and on oral hypoglycemic agents on regular basis. There is no history of major surgery or any chronic debilitating disease, no history of ischemic heart disease, tuberculosis or hypertension. Personal history: patient is a chronic smoker since 30 years with 4 to 5 BDs, consumption of 4 to 5 BDs per day. Diet: he is vegetarian, appetite is adequate, sleep is adequate, bowel and bladder habits are not altered. Family history: father is the known case of diabetes mellitus. There is no other significant family history. Summary of the case history: 51-year-old diabetic Hindu male patient outside operated for debridement of left foot, presented with raw area of left foot without any purulent discharge, swelling around the raw area and fever. General examination: patient is conscious, cooperative and well oriented to time, place and person. I have examined patient under...
Dr. Shweta, please wait. The examiners will take you through the history questions. Then we move on to the clinical finding. Examiners, please take over.
Okay.
What is the importance of putting it as Hindu male patient? What is that? What is the significance?
Sir, there is no such significance related to this case, my case, this patient, sir.
Then why should you write it? I think it is not needed.
It's definitely, it's not relevant, so don't mention that.
Okay, sir.
Yeah.
It's again, you said
Can
it
we go
is a
back to
51 years old male. We have been discussing in the last case that
He has not
51
said
years
it,
is not a old one. Okay.
Yes, sir.
So you can delete that.
Yes, sir.
Now, in this patient, you have to think, is it acute or it's a chronic one? First tell that.
Sir, it is an
Is it acute ulcer or it's a chronic ulcer?
Sir, acute ulcer.
Okay. Because of the
Duration.
duration, right? Now, second thing you have to tell that in this young patient of 50, I will say it's a young patient 51 years, what are the reasons that this ulcer, now we have seen the picture of that, there is a big ulcer which is there on the foot. So why this ulcer is not healing? You have to think about that only, even in the history also. Why there is a big ulcer which is there, which is not healing there?
Sir, patient is a known case of diabetes. Patient is obese. Patient is a rickshaw driver, and patient belongs to the lower socio-economic class.
So how does the rickshaw
Smoking.
driver and the socio-economic things come in the way?
Sir, lower socio-economic class patient will be m- malnutrition will be there.
Right.
I,
Agreed.
I just want to add one point, Dr. Shweta, that have you seen the rickshaw drivers, how do they operate their foot? For your information, patient is diabetic. Can you give some important information now? You know why I asked that question?
Sensation loss.
Patient is diabetic. They may have neuropathy, number one. So invariably, if you have seen, they don't wear chappals at all. Chappal means the whatever footwear. You know, very often they are used to manage that clutch and brake with the only with their foot. So heat, one is chances of the heat, chances of injury, and neuropathy. All these are possible. That is why this low socioeconomic group, not that others cannot be affected. I have only one objection to your raw area. I think at a postgraduate level, you can straight away tell ulcer. Okay, there's nothing like raw. Patient complains of ulcer in the leg. Over. Don't have to say patient's own words. No, don't have to worry about that.
Okay, sir.
Yeah, that's all. Sir.
Yes.
You know, you can basically divide whether there are any systemic reasons for that or the local reasons for that. You know?
Okay, sir.
So whatever you said, the patient is malnourished, or if a patient likes having the cancer cachexia is there, the patient is on the immunosuppressive drugs, all those things which are there. And then the local factors which are there is having a good nerve supply. Is he having a good arterial supply? Does he have a good venous drainage? And any other infective cause for that? Okay, so you can check these features only in the history itself. And then you can ask about all those things.
Yes, sir.
Shweta, can we go back to that slide where you talked about smoking habits of the patient? Yeah. Can you go back and tell us about it? What exactly you understand by that?
The patient is a chronic smoker since 30 years, consuming 4 to 5 BDs per day.
Okay. So what do you understand by that?
Sir, smoking it can be a factor which can lead to non-healing ulcer. It
Okay.
will lead to a chronic. It will lead to ischemia, local site tissue ischemia, which will be a positive factor for a non-healing.
Is there any classification which can grade the smokers? This years, number of BDs or cigarettes, kind of cigarettes? Does it have any grading?
Sir, I do not know, sir.
Okay. There is a specific WHO classification based on the duration, based on the type of cigarette, filtered, non-filtered, and then BDs, which are direct tobacco with raw tobacco in the leaves, tobacco leaves. So there is a definite grading is there, WHO classification is there. That will tell us about what factors you have described, but that this patient may be having these vascular problems. Okay.
That is called a pack years, no?
Yes.
Pack years is the quantitative estimation about the smoking.
Okay.
That how many cigarettes or VDs he was smoking per day for and how long he was smoking.
Yes, sir.
So that gives you a calculation of that.
Yes.
I could see Professor Jayesh Parekh raising a hand. Professor Jayesh Parekh, sir, anything you'd like to add, sir?
Yeah, it is aptly said that she must said the ulcer straight away rather than the raw area. And my two questions to the Sweta, what do you mean by ulcer? And second question, what is acute and what is chronic? What is your concept regarding this?
Sir, ulcer is a breach in the continuity of skin or mucous membrane. That breach in the continuity of epithelium, which can be skin or mucous membrane, followed by its removal either via infection or trauma.
So what is difference between ulcer and an incision? In both there is a breach in continuity. So what is different? The first part of your definition correct. ulcer, but due to what? It is not traumatic removal, it is something else.
Molecular death of the tissue.
Yes, that is the correct word, molecular death. In incision, it is a cutting of the cells. So this is the two major difference. The molecular death is most important word for the ulcer definition. Second question, what is difference between acute and chronic?
Sir, acute ulcer, the duration is within if 3 months, and if chronic ulcer, if it persists for more than 3 months, then we say it's a chronic ulcer.
So if it is 91 days, you are telling it is a chronic. And if it is 89 days, you are telling it is acute. So by your words, if it is a 9, so there is not a correct cutoff of the 90 days. It is something else.
So
and nothing regarding the ulcer, it is acute and chronic. If
So
you
there
go
is
by the, just tell, okay.
arrest of healing process will be there in case of chronic ulcer.
Okay. The question is acute and chronic. So in exam, what happens? You are just telling like this thing that 3 months. So examiner will ask you if it is 89 days acute and it is just after 1 day. So 2 days it becomes chronic. Natural, you will stuck up.
Yes.
So your answer should be the palatable. If I would be in your place, I would define the highest intensity of the symptom is plotted against the durations. And if it is make more than 45 degrees angle with the 0, it is acute. Less than 45, it is chronic. So nobody can challenge this one thing. Just like a mathematical angle. Okay, clear?
Yes, sir.
Okay.
Sir, can you just explain that, because I couldn't follow it up. What you are that 45 angle, but how is that?
So highest intensity of any symptoms or parameters is to be plotted on a y-axis and durations on a x-axis. And when you put, say for example, a 10 centimeter size swellings in a forearm is a small, but 10 centimeter swellings in a pituitary adenoid is very large. So it is a relative terminology. Whether big, small or large, it is every time it is a relative terminology where the swelling is. Just like that things, acute and chronic. So highest intensity versus duration is to be plotted on a graph. Okay. And if it is a make an angle of more than 45 degrees with the x-axis, it is acute. And if it is less than 45 degrees angle with the x-axis, is a chronic one. So this is because everyone understands this is what is acute and chronic, but when defining it is never by durations.
Sir,
I hope am I clear?
Sir, okay, sir, but with the due, it's very difficult for this terminologies to practically use it in 45 degree. What you are telling, let me complete.
Yeah.
Acute, my understanding goes like this: patient comes diabetic cellulitis, part is edematous,
yeah.
pus has been drained. Now this is definitely an acute stage. How we decide is edges are edematous. Pus is whatever the purulent material. So discharge, edema, tenderness, signs of inflammation.
Okay.
Now classical diabetic, say neuropathic ulcer in the, let us say, over the calcaneal region, etc. I'm just giving an example.
Okay.
Where the edges are indurated or thickened, no edema, no redness, no discharge. Obviously, we call them as chronic. I'm not sure about the number of days, sir. Not sure.
Yeah.
This is how we teach in our institution.
Yeah.
Rana sir, you'd like to give a sort of a sum up and clear this for the students' benefit?
Yeah, I mean, very quick comment for Sweta and the other students. One or two examiners said that you, instead of describing this as raw area, you should describe this as ulcer. Why are they saying? Like ultimately you'll have to go to the local examination. Suppose if you say it's a raw area, then in the local examination, you will say that it's a large raw area and it has got the pink granulation tissue. That's it. Now, if you say ulcer and then you describe it in the clinical finding, you'll be describing them in certain heads. And that will, like that you can impress the examiner. You can say about the shape, you can talk about the size, you can talk about the edge, you can talk about the margin, you can talk about the floor, you can talk about the base. And once you describe that, believe me, basically it's an ambiguous question. But if you have got this patient in the MS examination, then once you describe about the base and floor, this is a very favorite question of all the examiners, that, like what is base, what is floor, and all of you know it. So you will get an opportunity to talk about all these things. So and with the other examiners, that will be a good idea to describe this as an ulcer rather than the raw area. So that's all I had to say.
Sir, what is, please, sir. Yes, sir. Yes.
Yeah, the main confusion about, what Dr. Jay said, that, the students are not going to measure it there. They are not getting that they will draw a plot at y-axis and then the x-axis and measure that. The basic thing is it has been changing to define the chronic ulcer which is there. It was said that it is 3 months. Then in some area it came to 6 weeks. So I think if the student says that if there is a persistent ulcer, in spite of a good treatment, the ulcer is persisting for more than 6 weeks to 3 months, this is a chronic ulcer. If there's a bad ulcer is there, like just a traumatic ulcer which is there, which is not healing because there's so much of infection which is there, it is persisting. And he's not getting any treatment for that. It will persist. But basically, if the patient is getting a good treatment and still the ulcer is not healing in 6 weeks to 3 months time, this is called as a chronic ulcer. So the students can simply say that what Shweta was telling, that it like if it is a, there's nothing like a 29 days and 31 days or like that, It's like if we take the TNM staging, we say it is 5 centimeter or 5.1 centimeter. It makes a difference there, whether what it is, whether it goes to T3 or whether it goes to the T4. So I think it is not there, but basically the student must answer that if it is there for 6 weeks to 12 months, 12 weeks, it is not healing. This is a chronic ulcer.
More than the even the duration, whether the ulcer is going through the normal evolution process of a healing.
Yeah,
even an
that's right.
ulcer of a 5 centimeter can start healing, then it will be have a healing ulcer, but it takes some more time for it. Or sometimes even 3 weeks, 6 weeks, 7 weeks, it will be just granulated. If the process of staging, so different stages of healing is started, it is going through the normal stages, definitely it is an we have to acute ulcer. We cannot call it as a chronic ulcer. If an ulcer is not going through the stages of healing, it must be, the pus should be reduced, the epithelialization should there, granulation tissue should come, then we have to call it as a chronic. As rightly sir, Ajay sir has said, the 6 weeks and 3 months are the different cutoffs we are using. But mathematical, because surgeons are normally the poor in X and Y axis. That is very difficult for us to.
I would say, sir, was trying to tell about the physics behind the wound. I'm sure for recent advances and the standard candidates who are performing thesis work can definitely take up this as a part of their thing measurement. And I'm sure it is going to make a lot of sense, and one could arrive at a lot of statistical information about making this chart. I'm sure that grounds it will be a very sound method to analyze the volume versus duration part of it. Anyway, I think now with the air cleared, can we move to the subsequent things? Dr. Shweta,
Yes,
please go ahead with your clinical part of it, please.
Yes, sir.
Examination. Patient is conscious, cooperative, and well-oriented to time, place, and person. I have examined patient under well light and exposure with informed consent. Temperature is normal. Pulse rate is 86 per minute measured in right radial artery in supine position with normal force, normal volume, no radial or radiofemoral delay. Blood pressure is 130 by 90 millimeter of mercury in right brachial artery in supine position. Patient's body mass index is 26 kilograms per meter square. There is no pallor, clubbing or cyanosis or no generalized lymphadenopathy.
Wondering, will BMI you measure in the meter square? What is the normal,
Yes,
not is the normal surface area of an individual? What is the normal surface area of an individual? Adult of the 50 years old, when 50 kg individual. See, now if you say BMI 26 kg per meter square, then what will be the actual BMI for that individual?
I think you had the formula. You have to recover. Sir is trying to point out BMI is a composite number, right? How you arrive at that BMI is a different thing. So do not add up that kilogram per meter square at that point of time. That is the message Dr. Jailal sir wanted to bring in to highlight, because BSA, body surface area, is a totally different concept, and you have different things for calculating different parameters. Here, please do not bring that kilogram per meter square. That is the message you should clearly take up. If the examiner asks you, how did you arrive at 26? Then you say, I use this formula. You cannot put, see, if it is kilometers, 10 kilometers, then you can put 10 km suffix behind the 10. But if it is BMI, you cannot put 26 suffix by kilogram per meter square. Please understand that. It is a composite number.
Yes.
You get the message?
Yes, sir. Yes.
Please avoid this technical numbers with safety. Whenever you are measuring or mentioning a parameter of index of measurement, you have to use it precisely. So BMI is a composite number. That is a message for all the residents here, right?
Yes.
Go ahead, Shweta. Go ahead, Shweta.
Sorry, sir. Local examination. Inspection of the left lower limb, left foot. This is the dorsal view and the medial view. It shows approximately 10 by 8 centimeter size single irregular shaped ulcer over dorsal and the medial aspect of left foot extending above the ankle joint. Floor is formed by pink granulation tissue with punctate hemorrhages with minimum serous discharge. Edge is sloping. Margin is well defined. Surrounding skin is normal. Grade toe movement is restricted at metatarsophalangeal and interphalangeal joint. Rest of the toe movements are normal. Ankle joint movement is normal. There is no dilated vein and swelling over left lower limb and no surrounding skin hyperpigmentation. On palpation, the confirmation of the palpatory findings, ulcer of size of 11 by 8 centimeter size of irregular shape. It has pink granulation with which bleeds on touch. Base is formed by muscles. Temperature of the surrounding skin is normal. Surrounding skin is non-tender. Loss of sensation over the dorsum and ankle joint. Loss of sensation over sole. Passive movements at the all toes are present. Pulsation of dorsalis pedis artery and posterior tibial artery could not be assessed, and popliteal artery, I meant here spell error. Popliteal artery and femoral artery are normal. In opposite limb, there is loss of sensation over the sole region. Pulsations of dorsalis pedis, posterior tibial, popliteal artery, femoral artery are normal. Respiratory system is normal. Cardiovascular system normal. The central nervous system is normal. And case summary. A 51-year Hindu male patient, known case of diabetes mellitus, developed swelling with pain and foul-smelling discharge over left foot, underwent debridement with regular cleaning and dressing, presented with raw area over left foot with pink healthy granulation tissue with sloping edges without purulent discharge and fever.
Shweta, before faculty take over, don't run through your presentation. We could see you running up, giving so many facts in this speed. The one important message I'd like to give all the residents are, give pass between every relevant positive finding you elicit. Give pass between one finding to the next finding. So you're also clear, the examiner gets internalized. If you're going to run through, in this we have the assistance of PowerPoint. In exam, you do not have the assistance of PowerPoint. The examiner will definitely shoot back to you. You don't avoid, please avoid a confrontation. So go dogmatically. The floor of the ulcer is. The floor is formed by. In that speed, if you're going to go, your knowledge is effectively communicated to the examiner. I think I have two hands going up. One is from Professor Jayesh and Professor Hemant. If they want to add up questions now or at the end, they can add up. Please feel free to ask before the examiners take over.
The question to the Shweta is, why the temperature in an ulcer is not taken? What is the scientific reason behind it? We are taking temperature of the surrounding skin, not the ulcer itself. Why? Shweta?
Yes, sir. Yes, sir.
No, if you are unable to answer, please tell me much so that sir can tell you the answer. Then we move on to the other question.
Yeah.
Sir, please give the answer. Sir,
I don't know.
Okay. So each and every ulcer has a discharge. And due to the latent heat of evaporations, even if you take the temperature of an ulcer, it is always subnormal. Even if it is inflammatory ulcer, so it does not help in the differential diagnosis. There is only one finding, it is a subnormal compared to the surrounding skin. That's why temperature has not been mentioned in a palpation of an ulcer as compared to the swelling. In swelling, the first point is a temperature. Ulcer, that point is omitted because of these reasons. Okay.
Yes, sir.
Thank you, sir. Thank you. Dr. Hemant Kumar, do you have a question?
Suvita, you have put
So
as
it was regarding the history. It was addressed, sir. Okay. Please
Yes, sir.
continue.
Thank you. Faculty, please take over.
Suvita, you have put the metatarsophalangeal joint restricted movement. What are the movements at the metatarsophalangeal joints?
Sir, flexion and extension
There is only two movements.
and rotation.
Rotation.
Yes.
Is the word you use rotation or? What is adduction? What is circumduction?
Yes, sir. Adduction, abduction, circumduction, flexion, and extension.
So when you are making such a statements, please see that you are we have done that exam adequately, movement adequately. Why do you want to do that movement at this for this ulcer? Is there any significant or anything it is going to give you? You are going to spend for all the 5 joints. You are going to do all the 5 examinations. This is a short case you are presenting.
Sir, I could not.
Movements are restricted or movements that will be all the joints. Putting it very particularly saying at the interphalangeal joints, metatarsophalangeal joints is not needed when you are presenting a case of an ulcer.
Okay, sir.
Shweta,
Yes.
Shweta, you have said growth toe movement restricted and rest of the toe movements are normal.
Yes, sir.
Ankle joint movement is normal. Is that enough for that ankle or any other movements which you have not examined, which you have not mentioned? What other movements happen around the ankle and distal to the ankle? You mentioned metatarsophalangeal, interphalangeal, and you just mentioned one line, rest of the toes movements are normal.
Yes, sir.
Ankle joint movement is normal. There is one more movement that happens. Yes. Did you look for that?
4 foot front.
If you have not looked.
No, sir, I did not look.
You did not. So what do you look for? You have any idea or shall I tell you the answer?
Sir, at the talocalcaneal joint.
What movement?
Internal rotate.
You're not getting that one. Inversion and eversion. Where do they happen?
At the talocalcaneal joint.
They are called subtalar joints. Okay. 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 Right. Good.
Dr. Shweta, I have 1 or 2 questions to you. Did you look for evidence of arterial disease in this patient in your clinical examination?
Yes, sir.
What did you look? Have you written there anywhere?
Yes, sir. Pulsations I have written, sir.
No, not just pulsation. Anything else? Patient is a smoker, no?
Yes, sir.
30-year smoker. So anything else in the foot, in the toes, in that any changes in the chronic ischemia, at least to the opposite leg also? That's the importance of examining both legs whenever you are given a ulcer in one leg. That is one.
Question from Dr. Shanai, sir, and it is a very well documented in his books also.
That is one point. Second important point is you need to also look for carefully the diabetic neuropathy features. Of the toes, clawing. You know, clawing, claw. What is the reason for clawing of the toes? Hello?
Yes, sir.
Diabetic neuropathy, diabetic neuropathy, posterior tibial nerve. Okay, it causes the cloying. Cloying produces the pressure points when the patient is walking. The pressure points will precipitate the non-healing ulcers. So you need to mention evidence of erythema, evidence of a neuropathy in the leg. And you mentioned base is made up of muscles. See what muscles come there. Correct? I saw somewhere, correct, where you have written that base somewhere. I think better not to commit at this juncture. What muscles come there in the dorsum? Any muscles are there or mainly the tendons are there?
So mainly tendons, sir.
Oh, so it's very difficult to make out. Your answer, I know it's a tricky situation. Your answer should be, sir, I can't make out the base. See, unless you lift the ulcer, you can't really make out. It's only by anatomical knowledge you can tell, sir, probably this is the joint and tendons come there. Correct? And if they ask you DPA and PTA, posterior tibial artery, will you be able to palpate in this patient? You said ulcer is on the medial side also, correct?
Yes, sir.
See, show that ulcer. Show that ulcer. Yeah, just see there. Where did you feel the posterior tibial artery? So,
yes.
Is it?
Yes.
Were you able to feel it properly?
No.
Currently, no.
So I just want you to understand all these things in the examination, be practical. Okay. Many times we can't make out all those details. What we can make out is that even the induration or thickening indicates chronicity of the ulcer. That's all. That's all here. So,
Shweta, may I ask you a few questions?
Yes, sir.
Shweta,
yes, sir.
First of all, if you have a limb, you should always compare the limb length of the two limbs, girth, and all that kind of thing. All right?
Yes, sir.
You should mention about the gait of the patient. How does he walk around? Does he, because if you're going to do anything, is this limb usable or not? Right?
Yes.
Suppose we treat it, whether it's usable, whether he's using it or not.
Yes, sir.
What kind of footwear is he using? Is he using a stick? For neuropathy, you must mention about vibratory sense, positional sense, sense of fine touch and pain. All that has to come. And by the look of it, I think it's a rocker bottom foot. So you should mention the lower, the sole of the foot, whether if it's a rocker bottom foot, you get to require prosthesis. In spite of just giving him a coverage, he will not be able to walk. Right? So all these things are missing. About, I don't know whether you mentioned about lymph nodes or not. I just missed it. Whether lymph nodes are there or not. We have to find out whether this is infected or non-infected. Because if it is infected, then we can't even give a skin cover to it.
Yes, sir.
Whether the tendons are mobile, whether the joints are mobile or not. A lot of factors have to go into this before we can take a decision for treating this patient.
Yes.
Dr. Sweda, you have made out posterior tibial artery and dorsalis pedis artery. Where will you look at the anterior tibial artery pulsation?
Sir, between the two malleoli, lateral to the extensor hallucis longus tendon.
Yes, exactly. Midway between the two malleoli. Good. You are not mentioned about
bone. Against which bone?
You are
All
mentioning
the pulsations are felt against the bone. Jay.
Against the lower end of the tibia, sir.
Okay. And if you have to feel the posterior tibial, against which bone you feel that?
Against the posterior to medial malleoli. Again, the medial malleoli, that is the part of tibia.
No, which bone?
So tibia, sir.
Or dorsalis pedis. I'm asking about the dorsalis pedis.
Dorsalis pedis lateral to the extensor hallucis longus tendon against the navicular bone.
Navicular and the medial cuneiform bone. No? Right. And posterior tibial against which bone?
Posterior tibial against the fibula. Sorry, against the tibia. Medial malleoli, posterior to medial malleoli against the tibula. Tibia.
Popliteal artery against which bone?
Sir, popliteal artery, if it is measured in flexion position, in flexion position, then it is felt against the tibia, and if it is palpated in the prone position, then it is felt against the femoral condyles.
And femoral artery?
Femoral artery against the head of the femur.
Now, in this patient, do you think that we should do the ABPI? What is
No,
ABPI?
sir. Ankle brachial pressure index, sir.
So should we do in this patient or not?
No, sir.
Why no?
Sir, because I am not suspecting peripheral vascular disease in this patient, sir. There are no signs of ischemia, chronic ischemia. The pulsations are normal. Here I could not assess because of the ulcer, but rest of the pulsations are normal in the left lower limb as well as in the opposite limb and in the upper limb also, which I have not mentioned about upper limb, but they are normal, sir.
No, Dr. Shweta, I think the patient could be having atherosclerosis. They usually go hand in hand. Hypertension, smoking,
Yes.
atherosclerosis, and diabetes.
Yes,
they
sir.
They all go together. So you just cannot rule out that there's no arterial disease.
So in a long standing lower limb ulcer, you have to always measure the ABPI. You have to always rule out. Even if the ABPI you are not able to find out any difference is there, then what next? Like especially in the diabetic foot, what next you will do after the ABPI? What can be done? Which
Suppose you don't get
measurement can be
ABPI, what else can you do?
So we can go for color Doppler of the lower limb.
No, a simpler way.
Any other pressure you can measure?
Segmental pressure.
So
No, you can
in
put a
that
pulse
case, facing the
oximeter, sorry.
diabetic foot,
Yes.
You can put in a pulse oximeter and put a pressure this thing stuff around the limb and just see where the thing cuts off.
you can measure toe pressure. You know? Okay, you can definitely do the pulse oximeter of that how much is the oxidation there. You can also do the pressure studies for the toe pressure. You know what is the normal toe pressure?
No, sir, I don't know.
It's around 40 to 50 millimeter mercury. Okay.
Okay.
So if it comes less than that, then it's a patient with ischemia. So in the diabetic foot, what happens that these are not the major vessels that is involved. It is the microangiopathy which is there, and that can be reflected on the pressure studies. But if it is associated with atherosclerosis is there, then what do you think? What will happen to the ABPI? If there is atherosclerosis is there, what can happen to the ABPI? Will it increase or will it decrease? What is the normal? What is the normal ABPI pressure? Normal, how much is the range is there?
Sir, I have forgotten.
It is around 0.9 to 1.1. Okay, so you pressure difference between the brachial artery and the posterior tibial or the anterior tibial artery is around 0.9 to 1.1. But if it becomes less, it indicates the ischemia. But even if it is more, that is also not good. So it means that's a calcified vessel. Like you find if the ABPI is 1.3 is there, it means you are dealing with a patient with atherosclerosis. There's a calcified vessel, and that is why this pressure is coming more. So that is also not good. So both ways it is not good. If it is more, it is also not good. If it's less, it is also not good. Okay.
Suvita, when you are presenting a case of a diabetic foot ulcer, I mean like this, and if you say, I don't know toe pressure, I don't know ankle brachial index, that doesn't feels good. And then that's the way in which you are saying, I don't know toe pressure, I don't know ankle pressure, that means you are focused at only particular case and coming and presenting. Especially when you are presenting a case of ulcer, you should read this peripheral vascular disease and all the way in which how their examination has to be studied. That is not something which is a very extraordinary things which are asking. It is a very quite normal thing that PG should be expected to know. What is granulation tissue? Shabina, you said there is a lot of granulation tissue. What is the granulation tissue?
Granulation tissue, sir, it is composed of capillaries and fibroblasts, which
Is composed of fibroblasts or it is a derivative of fibroblasts?
fibrin and capillaries. Sir.
So proliferation of fibroblasts. And you are saying pink healthy granulation tissue. Is there any other color healthy granulation tissue is there?
Sir, pale granulation tissue.
No, you said as pink healthy granulation tissue.
Yes,
so what
sir.
other colored healthy granulation tissue you get? Oh. She's missing.
Or maybe, I think, Shweta, the points are like this. What we speak amongst our friends, PGs, when you're presenting, maybe when you want to post this case for a grafting or something, then it is okay to tell it is pink and the wound is well granulating. But when you're presenting, you have to, every word makes a particular purpose. That is what Jailal sir is trying to tell, right? Don't be just perturbed, just get back to your balance quickly. He is trying to bring out the knowledge of yours in the right possible way. That is all. Right, you're going good. Get yourselves oriented back. The message is loud and clear. When you talk about every word in a clinical presentation during an exam, your words have to be very clearly measured. You tell, if you want, you can tell the wound color is pink. There is healthy granulation tissue. That will be a safe way to get out of the exam. Is that fine, Shweta?
Yes.
Rana sir, you wanted to add something, sorry.
I mean, I'm going to repeat what has already been said. But why am I repeating? Because it is very, very important. One, when Shweta said that base is formed by the muscle, that is totally unacceptable. So it has already been, like pointed out by the examiner, but I'm repeating that you have to be very careful that there is hardly any muscle there. It's all about the bone and the tendon. So that was one. Second, palpating the dorsalis pedis and posterior tibial artery here. That means you are going to wear a glove and poke through the granulation tissue to, like palpate. And all the clinical tests which possibly can hurt the patient has been shelved in the archive of surgery. So this is an absolute no. You cannot say that like palpated the dorsalis pedis and the posterior tibial, because you will have to poke through the granulation tissue, which is not the best thing to do. I mean, that's and both the points have already been talked about the examiner, the other examiner, but I just wanted to reiterate that it is important. And that's all. Thank you.
Yes.
Again,
Shweta.
very nicely told, sir. Rana sir has told. Just to demonstrate the bleeding on touch, don't scratch and scrape this ulcer. This I have seen in the oral cavity. Somebody is trying to, especially oral carcinoma, tongue and buccal mucosa, really moving the fingers and demonstrating the blood. It is not acceptable. Okay, right? See, the word is gentle palpation if it bleeds. That is what is the sign of easy friability. Easy friability. You understand, no? So don't try to say that loudly and clear that I did like this and caused bleeds on touch. Yes, sir. Please.
Diagnosis.
Shweta, one thing.
Yes, sir.
Just one thing that I think you missed is that the patient, I think somebody has already pointed out that the architecture of foot is lost. It is very important. This patient will not only require grafting, but some kind of prosthesis. Number one. Number two, you said something about the sensation. Can you tell what sensations are lost?
Sir, all sensations are lost, sir. Vibration sensations, touch sensations, pain sensations.
Okay, everything is lost.
Yes, sir.
Okay, fine. Thank you. Good presentation.
Good.
Diagnosis.
So what's your diagnosis?
Sir, my diagnosis is diabetic healing ulcer over left foot.
Just 1 minute, Dr. Shweta. That's fine. Diabetic ulcer foot for me, but examiners expect you the clinical classification and pathological classification so that you can make a good final definition. So, can you improve your classification? It's like telling, carcinoma stomach with metastasis or something like that. What is the clinical classification? You are written there healing, except. Yes. So in the non-pathological classification?
It is non-specific.
So it comes under that category. All right, I accept it. Fine. Go ahead.
What do you think it is a diabetic foot? Diabetic ulcer?
Sir, there is a history of trivial trauma following which patient developed swelling and hello.
Yeah, ulcer following trauma is a traumatic ulcer.
Sir, but patient,
Why do you call it a diabetic ulcer?
Just because he has a diabetic, that doesn't mean it is a diabetic ulcer.
sir, patient has a diabetic neuropathy for which repeated trauma must be there.
Where do you get the trauma in diabetic neuropathy? Dorsum? What is the trauma you normally get a diabetic neuropathy?
Whole regions.
Whole region. Soul region. Is it a which neuropathy? Diabetic sensory neuropathy, motor neuropathy, or autonomic neuropathy?
The sensory neuropathy.
Is there any role of autonomic neuropathy in diabetic ulcer?
Yes, sir.
What is the role?
Sir, there will be dry skin and
So be careful when you are saying a case, especially mainly you are talking the case on the dorsum of the side of the foot, putting as a straight away saying as a diabetic, just because he has a history of diabetes. If you say it is a diabetic ulcer, that would be to explain that what is the cause. Usually diabetic ulcer is a very long process ulcer. It is follows a neuropathy, or if it's a vascular lesion is there, then you can suggest other areas you can get. And you must be a little more cautious in putting as a diabetic ulcer. We can say it is an ulcer. Patient has a diabetic patient. That is a different meaning on that.
okay,
Why do you say it is a healing ulcer?
the patient, the ulcer has pink granulation with sloping margins, and there is no surrounding edema, redness, and no signs of systemic infection.
Discharge, what discharge you'll have in healing ulcer?
Sir, serous discharge, minimal serous discharge will be there.
Yeah, that must be also ordered.
Can you grade this diabetic foot? Do you know any grading system for the diabetic foot?
Yes, sir. Wagner's classification for diabetic foot. Sir, this will follow into grade 1, sir. Grade 1 category.
Why you say it's a grade 1?
Sir, there
Tell
is
the various gradings.
yes, sir. Sir, grade 0, that is the foot at risk, where there is no any skin loss. Grade 1, there is loss of skin, and in grade 2, there is involvement of skin, subcutaneous tissue, tendons, ligaments, and joint cavities. In grade 3, there is abscess formation with involvement of bones. In grade 4, there is in grade 5, there is a necrosis of the gangrenous changes involving the forefoot, and in grade 6, there is gangrenous changes involving the whole foot.
So your patient with there's a big ulcer is there, but it is a superficial ulcer.
Yes, sir.
There is no involvement of the tendons here, muscles here, the bones here. So this will be superficial ulcer. Okay.
Yes,
So
sir.
you have to always, like we give the TNM staging in the cancer of the breast. Similarly, also if you are suspecting a patient with a diabetic foot, you have to always grade that. Tell that what is the grading of that, because your treatment will depend on the grading of that, what you are going to do for that patient.
May I correct you? Wagner's is 0 to 5. There's no grade 6 there. 0 to 5.
Yeah,
Okay,
5.
0 is normal and 5 is gangrene.
Right.
Right. And patchy gangrene is 4. Deep ulcers with abscess is 3. Just deep ulcer with exposure of this thing is 2. And 1 is superficial ulcer. 0 is normal.
Yeah, intact skin is there. Yeah. Skin is intact in that. Yeah. Okay, Shweta. So keeping a diabetic foot ulcer here, how you are going to investigate your patient for making the diagnosis? First, you have to make the diagnosis.
Yes, sir.
Yes.
Sir, I would like to go for hemoglobin of this patient and HbA1c.
Hemoglobin is not going to tell you about the You know, always first your intention is to make a diagnosis. So for making a diagnosis of the diabetic foot ulcer, what investigations you will do?
Sir, glycated hemoglobin. I would like to know the level of glycated hemoglobin level, random blood sugar.
What is that called as glycated hemoglobin?
HbA1c.
Yeah, you will do the HbA1c. And what does that show?
Sir, if it is raised, then it will we will keep.
No, what does it tell you exactly? What
Sir,
does the glycated hemoglobin tell you?
Level of past 3 months of the patient.
Right. So it will tell you the average blood glucose level of the last 3 months. Right. What is the normal HbA1c?
So normal HbA1c is from 5.4 to 6.5.
Right. Okay. And can you tell by the level of the HbA1c whether his diabetes is controlled or not?
Yes, sir, we can.
How will you tell that? That his diabetes is controlled?
Sir, after starting the treatment for diabetes, we'll go for HbA1c after 3 months, and we'll see if the
If his HbA1c comes 6.5, so is it a controlled diabetes or not? Is it a good control or not?
Yes, sir, it is a controlled diabetes.
It is a good control. And if it is more than 8 is there, then it is an uncontrolled diabetes. Right. Then what else you will do apart from the blood glucose and the HbA1c for making the diagnosis of the diabetic foot?
Sir, color Doppler of the patient.
Yes, you will do the color Doppler. And what can you get the finding in that?
Sir, atherosclerosis of the vessels.
Yes. You can find the atherosclerosis. If you do a plain X-ray of the foot here,
yes, sir.
What findings you can see here?
Sir, if any bony changes are there or not, if changes of osteomyelitis.
Yes. You know, his foot is deformed clinically. You know, if you see, his foot looks deformed.
Yes, sir.
What can you find?
Yeah. Sorry.
Yeah, Dr. Shanoy, please, you can carry on.
Color Doppler, you just stopped at one half sentence. What did you tell? Flow, something. What is it? What did you tell?
So
arterial Doppler. Yeah, what did you tell?
Sir, it will show the stenosis of the vessels or whether it's flow of the vessels, sir.
Yeah, that's all you said. But see, please remember, you need to, you said, I think, atherosclerosis. What you need to do,
atherosclerosis, yes.
You don't see, you are a postgraduate. Most importantly, you start from the nature of the vessel. That is okay. Atherosclerosis. Like TAO, you'll have a segmental. Whereas atherosclerosis, you will not find that kind of a segmental, number one. Second thing is the velocity. You need to mention all these things. Have you seen a color Doppler report?
Yes, sir.
Do they not mention velocity? Next, second, third, nature of the vessel. They always mention monophasic, biphasic, triphasic. See, these are very important points. What do you mean by triphasic? Triphasic means what? You have an arterial phase, you have a venous phase, and then there's something called as a elastic recoil. Elastic recoil. Is it clear? So that's called as triphasic. Are you hearing? Following?
Yes, sir.
What is meant by biphasic then? This happens when there is atherosclerosis. Vessels get calcified. Dr. Khanna sir has mentioned sometimes. Then you get some kind of a biphasic. So much severe, you get monophasic. See, these are all the important points. Also, should be mentioned in your presentation. It will fetch you more marks. That means your understanding will be better. And whenever you have an opportunity in your institution, please go to the Department of Radiology once at least. Have a look at the color Doppler of both, arteries as well as the venous, all that you need to follow. So that stenosis, velocity, all the details to be made out so that to plan for the actual revascularization, etc. This patient is diabetic, maybe having a more component of this ulcer management, but this will definitely, these questions will be asked. Okay. Yes. Standard triphasic form you should know, and what is monophasic, biphasic, triphasic. Okay, right. That's all, sir.
So what can you get in the plain X-ray? I was asking. No,
Sir,
if you look clinically, also his foot looks deformed. And it is not a normal foot.
Yes, sir.
So what are the various abnormalities you can see in the bones of a diabetic foot?
Sir, changes of osteomyelitis, or we can see Charcot's joint.
Charcot's, yes, that's very important, because this foot looks like a Charcot's foot, which is there, and there it is not a osteomyelitis. Okay, it is the destruction of the bone which is there. Okay, osteoporosis is there.
Yes, sir.
Then if it is atherosclerosis there, you can see the calcified vessels there. Sometimes you can see the calcified dorsal artery, you can see on the plain X-ray. So all those things you can see on the plain X-ray. And that can also give you an idea that are you dealing with a case of a diabetic foot or not. And your treatment will also depend. If the patient has a Charcot's foot, the treatment is different. And if it is bones are absolutely normal, the treatment will be totally different in this patient.
Yes.
Then what else you have to do for this patient? There's a big ulcer is there for making the diagnosis. You probably thought it's a diabetic ulcer. Now you have to see that how much is the density of the infection there. So how will you assess the infection there?
Sir, swab culture of the raw area of the ulcer.
So do you think the swab culture is good for a patient who is having such a big ulcer which is there, which is superficial ulcer?
Sir,
you have to really see that what are the organisms there. Do you think the swab culture will satisfy that? Or you have to take a tissue culture here? Okay. You have to always take the tissue culture because if you just do a swab culture from the surface only, this will be in a mix of the microbial flora will be there. So that is not going to help you in your management. You have to take a deeper culture here. You have to take a tissue culture for that. And you have to see that what bacteria is there. Because based on that, again, you have to see that how much the quantity of that. It is not necessary. If it is colonized, you are going to give the treatment for that. But if it is infected is there, definitely you are going to give the treatment for that. Okay.
Yes, sir. Yeah.
Then what you will do?
Sir, serum protein level of this patient.
Right. You want to see the nutrition status of this patient?
Yes, sir.
For assessing the nutrition status, what you will do?
Sir,
what test you will do to assess the nutritional status?
Sir, mid-arm circumference, skin fold thickness.
No. Now we are on the investigations.
No. Investigations. We are not going clinically now. You want to know the nutritional status, no? What test you will do? You mentioned earlier, what is the test?
So you would definitely do the hemoglobin of this patient. You will see for the albumin status of this patient, at least these two things. Then there are so many things which are there, the ferritin and all those things will be done. But at least that these two things has to be there, the hemoglobin of the patient and the albumin status of this patient. How much is that?
Yes, sir.
So what are you going to do for this patient?
Sir, I would like to go for split thickness skin grafting.
Directly? So that is your first approach?
Sir, patient has already regularly cleaned and dressed for past 1 month.
Okay.
Sir,
So he's already prepared. That's what you meant to say.
Yes, sir.
Okay.
Suppose if your culture shows beta hemolyticus, streptococcus, will you proceed with the skin grafting or?
Sir, the quantity of the organism.
This class is going, Kana. I will finish the class and speak.
Sir, I would straight like to go for split thickness skin grafting.
No, beta-amyloid receptacles totally contain absolute contraindication for grafting. It doesn't depend on quantity.
Yes. You should not do grafting in the presence of beta hemolytic streptococcus. Okay.
Yes.
Okay, Dr. Shweta, just one question. What is offloading?
Sorry, sir, I could not hear you.
What is offloading? What is the basic principle of trying to get the ulcer heal in a diabetic foot or any foot? Offloading is you have to bring down the pressure. You have to you have to prevent the patient from putting pressure on the affected leg, because that is going to prevent healing, right? So what are the methods of offloading?
Sir, giving the cast or slab over the involved foot, involved
So
lower.
you'll cover the ulcer then.
Yes.
Huh? With a cast.
For the ulcer, no.
Sir, will immobilize the joint, sir.
Okay, how do you do that?
Sir, by providing slab.
You have to give some support, right? A foot. These people usually can have foot drops. They can have, so you have to give a support which is customized to the patient's shape of the foot, right? You have to give him some form of non-weight bearing or partial weight bearing, right? All that kind of things. So you have to get in the physiotherapist to get this. This is very important before you go in for SSG.
Okay.
Okay, Shweta, you have done a graft, split skin graft. You have done.
Yes.
What are you going to observe in the next 2, 3, 4, 5 days? What are you going to see in this patient?
Sir, in the whether there is any discharge or
okay,
whether the graft is floating or not. That is
so you would like to see graft is taken up or not.
taken up.
So when do you see that?
Sir, on the post, we'll first open the dressing on the post-op day 2, sir.
First?
Post-operative day 2.
Day 2.
Post-operative day.
So it's 48 hours to
48
72 hours.
Yes.
You would inspect the graft and see whether it is. What do you mean by partially taken up or 100% taken up? We say now. What do you mean by that?
Sir, the graft which we have taken up, whether it is 100%, whether it is completely in the position or not, the part of the graft may be lost, sir. Then there will be partial uptake of the graft.
In a large area, what is the best method of putting a graft?
Sir, patch graft, multiple patchy grafts.
Multiple. Where do you call that? What do you call that? Yeah, something like a mesh graft. What do you say that? Okay. 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 Sir, Rana sir, I think you can summarize. I think we are almost closing.
What is the time principle of wound management? Have you heard about that? Shweta?
Sir,
have you heard about the time principle of wound management? What does the time stands for? Okay, time is T is for the tissue debridement. So whenever there is an ulcer is there, you have to debride that. I is for the infection control, which is there. You have to control the infection. M is for the moisture balance, which is there. And E is for the edge control. If your edge is becoming inverted, you have to make it a sloping edge, right? So these are 4 things which are there in the time principle. Now tell what are the various ways to carry out the tissue debridement?
Sir, it can be chemical or it can be a surgical debridement.
No, you can remember it with the beams. B is biological.
Yes.
E is enzymatic. A is autolytic. M is mechanical. And S is surgical. Because these are 5 types of the debridements which are there. But the best debridement is the surgical debridement. You know what is the biological debridement? You
So
understand by that?
maggots. Maggots.
Right. So these are the simple maggots which are there in our home, or they are the different maggots? No, they are different. No? They are usually produced in the laboratories. They are the green bottle maggots which are there. No? From Lucilia. That is the type of the, what's that? Type of the type of the fly, yeah, for the type of the fly which is here. This is the green bottle. So those are used for the biological debridements. I think go ahead with your Dr. Prasad question. He was asking what you will do in the post-operative. How does the skin graft is accepted by the body?
Sir, it is Sir, there are 3 stages of uptake. That is the stage of imbibition, where there is plasma exudates from the host capillary bed, which nourishes the skin graft. Stage of revascularization.
For how long does it go?
Sir,
for how many?
For 48.
Yes, only for initial 24 to 48 hours. Okay.
Yes.
Right. Then what happens?
Stage, there is the formation of capillaries in the graft vessels, and then anastomosis between the graft and the host capillaries. And second, which again goes from 3 days from 3 to 7 days. It lasts for 3 to 7 days, and the stage of organization, which is formed by for fibrin deposition and fibroblast.
Now, tell what are the places where you cannot do a skin grafting. There's a raw area is there, but you are not able to put a skin graft. And that is why the Wagner's grading which comes in the picture here.
Sir, if there is a bony involvement,
yes,
then skin graft will be difficult.
So do you think if there's a bone is there, you cannot put a skin graft on that? Like if there's an ulcer of the scalp is there,
Sir,
and you can see the bone there, can you put a skin graft there or not?
Yes, sir. After bony drill, we can put a skin graft over it.
So why you want to do a bony drill?
Or allow the granulation tissue to develop, sir.
Your main aim is that periosteum should be there. If the periosteum is there, then it will take up. But if you remove the periosteum, then this bone will not take up the graft.
Yes.
Similarly, the tendons should be with paratenons. If it is without the paratenons are there, the graft will not take. Similarly, the nerves which are there, if there's a paraneurium is there, perineurium which is there, then it will take the graft, otherwise it will not take. So that is the important of Wagner grading here, that you should know that whether these tendons which are exposed are without the paratenon, is the bone which is a necrosed one, or it's along with the periosteum, then only you can put the skin graft.
Okay.
Yeah.
What are the places where you will not put the skin graft? Like with ulcer on a bone, on a joint is there. Will you like to put a skin graft or not?
No, sir. I would try to avoid it.
What will happen?
Sir, there will be development of contracture, and joint movement will be hampered in future.
And this will become like an unstable scar. And if the unstable scar is there for a very long time, what can happen to that?
Sir, Marjolin's ulcer can develop.
You can develop the margins ulcer over there.
One last question, Shweta. I think if all examiners agree, I think probably the last question. How do you manage the donor area? We never concentrate on donor area.
The donor area, sir, we keep it dressed for 21 days via.
You keep it dressed for 21 days. You don't touch that area?
No, sir.
So what do you do? What dressing you keep there?
Sir, we
And
apply we apply liquid gelonate dressing over the donor area.
Okay. And then what do you observe?
Sir, we do not open it for 21 days, and following that we can apply coconut oil over the donor area, sir.
No. See, basically, you're supposed to not to touch it until it becomes loose on itself. Loose on itself. Okay. It's not that 10 days or 21 days or 28 days or not. And then coconut oil is not now, it's not the current vogue. Okay. So you need just some moisturizer subsequently. That's it. But okay. So you have to wait for the dressing to get loosened up and then only you touch that. That is the idea of managing the donor site. I think Rana sir or Kanakavel sir should summarize this. And
two quick comments. One, the same thing when I was talking about the palpation of dorsalis pedis and posterior tibial in this area. If you are really looking at arterial compromise, then doing Doppler is also not going to be easy. I mean, of course, we can overstretch by saying that we will, have a linear probe, cover it with the sterile, like a plastic sheath, and there'll be jelly inside that. You can do that, but this is too cumbersome. So, doing Doppler in that area is also not going to be easy. You have other methods. You can do CT angiography, you can do DSA to know about the arterial tree. And certainly it is important in a diabetic patient, because if it's a compromised arterial tree, then healing is going to be difficult. And as far as the organism is concerned, when will you not do it? If the, like culture has grown pseudomonas, then you will not put a, partial thickness skin graft. Needless to say that this area should be as close to sterile or bereft of organism as possibly it can. Then partial thickness skin graft you can put. So that's all I have to say. And Sweta, I must compliment you. You have really held the ground very firmly and very nicely. That's all. Thank you.
Any other comments? Hemant sir, did you want to give any comments, sir? I think he is not with us.
Yeah. It's
Shweta,
good
do you would like
presentation.
to ask any? Thank you, sir. Thank you. Shweta, you would like to have any clarifications done before we close up? I'm sure you have been reading quite a different textbooks and recent advances also. I could see the way you are answering, catching up the questions. I'm sure when you read more doubts come into your mind. What is the most troubling doubt you have ever heard in reading, preparing for this patient?
I was troubled about the examination parts.
Fine. The examination comes by repeatedly seeing a patient, repeatedly re-examining the patient, same patient, and then do not miss an opportunity to see a patient, even if it is not admitted into your unit. In general, what we do in our PG days is Saturday afternoon will be other unit rounds. So it will be a group rounds. Faculty sometimes will be there, sometimes will not be there. But you get to see into other departments, visit orthopedic department, visit radiation oncology departments, visit surgical oncology departments, all other departments. You get to see many unique cases. You examine repeatedly, then you get a flare of and do not miss to take classes for the undergraduates. Do not, postgraduates, make a point, you take classes for the undergraduates in hostel, in the ward, bedside, during night calls. That is the most important thing, because undergraduates are now very sharp. They will catch you up for all, because they work by logistics, size, shape, surface. They will never miss anything. So teaching undergraduates is one of the best things for PGs to be sharp in their findings and their presentation. That is what other faculty can add up. Mardu sir and Apurva sir, I think all of them have been teachers for
Yes, regarding Dr. Sweda, you should not worry about examining the ulcer in the foot. Apart from routine examination of any ulcer, in addition to that, you must look for arterial venous deficiencies, joint movements, bony involvement, base, whether it is what is made up of, whether it is muscle or bone or like that. So very 4 or 5 points you must concentrate while describing the foot ulcer.
Yes.
That is lacking many a time.
Thank you, sir.
It should be concentrated.
Well done, Shweta. Actually, you've done well.
Very well done.
Good presentation.
Thank you, sir. Thank you, the senior faculty, Professor Rana Singh sir, Professor Apurva sir, Professor Prasad sir, and Marudhu sir.
Thank
And
you.
I think I
Thank you,
should
sir.
thank all the senior faculty of staying with us, Professor Kanna sir, Professor Shanai sir, Andarya sir, Karnakaran sir, and Prakash sir, and all other senior faculty who've been with us. I'm sure today's thing was quite energetic.
Informative.
That's what. And I would look forward to have more intense deliberations in this way.
Wonderful.
Thank you, dear faculty. Thank you, students in the YouTube channel. And we will look forward to yet another session in the coming week. Good night, faculty. Is there anything any faculty would like to add? Or shall we call it a close, sir, please?
Thank you all.
Bye bye, sir.
Whenever you are doing any examination,
sorry, sir.
Just a minute. Whenever you are doing examination on any ulcer, you are always wearing the gloves.
Yes.
Okay. And whenever you are wearing the gloves, you can very well examine the underlying arteries which are there. Okay. You will not trouble the patient by, you are not going to poke it there. You are just going to put your fingers there right only, say whether it is palpable or not. And even the ultrasound which is there, ultrasound nowadays, whenever you do, you use the jelly for that. So the radiologists, they are always in the way to carry out this one. So you can simply put a jelly there and examine the arterial supply which is there. And I will not advise to go for a angiography for these patients. Angiography is either you do you are planning for a vascular reconstruction. Then this planning is for that. But just for the screening purpose which is there, the duplex scan which is there is good enough to tell you. But definitely if you are going for any reconstructive procedure, any vascular procedure you are going to do, you will do the angiography.
Well said, sir. Well said, sir. Well said.
Thank you, sir. Thank you, one and all. Thank you, dear students who are on the YouTube. Thank you for joining us this evening. I look forward to meet you in the coming Friday. Good night, everyone.
Good night, sir.
Bye.